Good morning, good afternoon, and good evening. Your Excellencies, colleagues, ladies and gentlemen, welcome back to the 148th session of the Executive Board. We shall now continue with our consideration of sub-item 17.1, Proposed Program Budget 2022-23, and consider the revised draft decision on sustainable financing as contained in document EB 148/conference/12 add 1 revision 1. The financial and administrative implications of this draft decision, should it be adopted, are contained in document EB 148/26 add 2. I would like to invite the Vice Chair, who is present in the Executive Board room, to update us on the consultation that took place on Saturday evening. Mr. Kumal, you have the floor, please.
Thank you, Chair. And indeed, as we ended the meeting on Saturday at 5 o'clock, we started the consultations on the draft decision at 5:30 Central European Time. We were working on the Chair's proposal, and we had very constructive discussions and debates. I think that we reached a very good text based on consensus. I will currently just run through the text so everybody's aware. The text is available in the conference paper, so everybody should be able to have had a thorough look at the text. So the Executive Board has decided to establish a time-bound, results-oriented working group on sustainable financing open to all member states. So I think that was one of the key discussions that we had, whether it should be a smaller group or really a group that should be open to all member states. And the drafting group, came to the decision that we should focus on this inclusive, broad group where really every member state that wishes to engage on this important item, sustainable financing, would be able to contribute on an equal footing. So that, I think, was the key decision that we took. We then clarified the mandate in para 1. We also agreed that the working group should take into account the relevant work that of WHO and other relevant bodies on sustainable financing. So we are not starting from scratch in para 3. We are clarifying that it's up to regional consultations, which should be finalized by mid-February, that the working group shall have 6 officers from each region 1, and to have a chair and a vice chair that should facilitate the work of the working group. The first meeting is supposed to happen by March, and there will be then an interim report to the next World Health Assembly through the PBAC, also this interim report will be coming to the regional committees this year, and then a final report to be submitted with recommendations and other findings to the Executive Board in a year's time through the PBAC. I think that this text is now very, very clear. We reached a consensus. All delegations showed great flexibility, and I would want to wish to thank all delegations for this flexibility and the great constructive spirit that we had in the meeting. We were able to finish by 9 o'clock, also through the help of the interpreters who were with us for quite a while. And I think that's my report from the discussions. Thank you very much, Chair.
Thank you, Mr. Kumal. Is the board ready to adopt the draft decision on sustainable financing contained in document EB 148/conference/12 revision 1? I see no objection. The decision is therefore adopted. Thank you. This concludes our consideration of sub-item 17.1. We shall now consider together items 15.1, poliomyelitis eradication, and 15.2 Polio Transition Planning and Polio Post Certification. The relevant reports are contained in documents EB 148/2022 Poliomyelitis Eradication. The board is invited to note this report and focus its deliberations on remaining operational challenges to reaching every child, rollout of novel oral polio vaccine type 2, and ways to mitigate risks posed by a precarious financial situation, and EB 148/23, that's about polio transition planning and polio post certification. The board is invited to note the report and to focus its deliberations on the best way to support the implementation of polio transition activities within the context of COVID-19. The floor is now open for discussion. I would like to request that the Secretariat moderate the discussion on the virtual platform. Secretariat, you may have the floor now.
Thank you, Mr. Chair. May we kindly remind those wishing to make an intervention to please raise their hand in the Zoom platform. We might just give member states a moment to do so. Thank you. We understand that there is a technical issue whereby member states are unable to raise their hands. If we may suggest that we take a very brief moment to pause so that our team behind the scenes may work to rectify this issue. Thank you very much. Over. Thank you once again. Our teams behind the scenes are working hard to rectify this issue. We understand that Burkina Faso would wish to make a regional statement on this agenda item. If I may suggest through the chair that we would try and connect with Burkina Faso in the first instance. Thank you, and Burkina Faso, you have the floor.
Many thanks, Ms. Moderator. Burkina Faso is taking the floor on behalf of the 47 member states of the African region of the WHO. We thank the Director General of the WHO for his 2 reports on poliomyelitis, and we congratulate the Secretariat for the considerable progress it has made in the fight against this disease. The African region is pleased with its certification of being exempt from wild poliovirus on the 25th of August 2020 and the efforts deployed to put an end to residual transmission. The COVID-19 pandemic has perturbed the actions against PM, including vaccination campaigns. This is why the African region is pleased with the measures taken by the Secretariat. The region would like to remind everyone that it's urgent to find innovative ways to continue to carry out efforts and putting the accent on coordination and the involvement of all those involved, including populations, this to avoid new outbreaks of the disease in certain countries. Sir, the African region would like to draw the attention of all stakeholders the need to strengthen financial mechanisms to fight against poliomyelitis. This to reduce the risks given the fragile financial situation. Indeed, the end of funds allocated to the region that have been announced between now and the end of 2021 means that we need to mobilize long-term financing to allow the region to continue its activities, its elimination activities after the transition of poliomyelitis. The African region asked the WHO to add financing for poliomyelitis and put it in one of the priorities of the program budget for 2022-2023 and following budgets. In addition, the financing coming from internal country resources from development partners should be mobilized to guarantee an efficient implementation of transition activities, which should ensure that poliomyelitis disappears forever, and to provide assistance to other public health interventions that, for example, vaccination and management of emergency health situations. Also, we are in favor of the revised elimination strategy and invite member states and those involved to make sure necessary resources are available, including financial resources, to deal with the disease and to avoid any sporadic outbreaks. Sir, successful transition from poliomyelitis means the integration of various different functions. This includes monitoring and national vaccine programs, which means that resources have to be available, including financial resources over the long term. To do this, the implementation and the execution of national plans should allow us to ensure that the successes that we've achieved throughout the world are long term. The African region takes note of the report and invites the Executive Board to do the same. Thank you.
Thank you very much, Burkina Faso. We shall now invite the distinguished delegate from Tunisia to be followed by Austria. Tunisia, you have the floor. We understand that Tunisia would wish to make a statement on behalf of the Eastern Mediterranean region. With that, once again, Tunisia, you have the floor. And we shall return to Tunisia. May we now move to Austria? Thank you. And Austria, you have the floor.
Austria thanks the Secretariat for elaborating the two reports on polio eradication and polio transition planning. As we all know, polio programs have proven to be a highly effective tool, not only for carrying out polio vaccination campaigns, but also as a line of first defense in order to mitigate and contain COVID-19 outbreaks in numerous countries. Furthermore, polio eradication programs will also be of critical importance in the future rollout of COVID-19 immunization programs. Like in other areas, however, COVID-19 has led to an interruption or suspension of polio programs that now need to be relaunched and continued in order to avoid a severe backslide. With population immunity against polio and other communicable diseases like measles dropping due to COVID-19, the world faces a potential storm of vaccine-preventable disease outbreaks. In addition, we see an exponential increase in communal cases from 2 in 1916 to about 660 in 2020. The recently launched novel oral polio vaccine will be a significant step forward to stop vaccine-derived polio virus type 2 outbreaks. In order to implement the GPAI response strategy to the measles outbreak, urgent funding is required to stop these outbreaks. It is of high importance to finance the polio eradication cost mentioned in the emergency call for action launched by the DG in November 2020, asking for additional funds for polio eradication for $400 million for 2020 and 2021. Thank you very much, and I yield back to you.
Thank you. And we now invite the distinguished delegate of the United States of America to be followed by Bangladesh. United States of America, you have the floor. United States of America, just confirming that you're still in a position to deliver your statement. Thank you. And United States of America, once again, just confirming that we can see you, and we understand that you're unmuted and should be able to deliver your statement. Thank you.
Chair, if you can hear me, the statement is to be delivered by Delegate Rebecca Martin.
Thank you for informing us. We'll do our best now to locate your colleague and ensure that they're unmuted and able to deliver the statement. And once again, we do ask that the chair and colleagues here in the room and member states bear with us. Once more, we're unable to see hands raised. The team behind the scenes are working to rectify this. However, we shall take the United States of America, followed by Bangladesh. And now to the United States.
Thank you. The United States commends the Global Polio Eradication Initiative on making polio assets available to support the COVID-19 pandemic response. Polio-funded staff and assets have contributed to the response in over 50 countries. The United States remains concerned about the circulating vaccine-derived poliovirus type 2 outbreaks, CVDPV2, in 3 of the 6 WHO regions, especially in the African region. We support the urgent introduction of the novel oral polio vaccine type 2, NOPV2. In addition, as preparations for the rollout of NOPV2 continue, it is critical that monovalent oral polio vaccine type 2, MOPV2, is used now to stop CVDPV2 outbreaks. Member states should prepare for the introduction of NOPV2, including safety monitoring and surveillance, which will be of value for the rollout of COVID-19 vaccines as well. The United States is extremely concerned about the spike in wild poliovirus transmission in Afghanistan and Pakistan due to several issues, including access challenges and consequences of the pandemic. The United States fully supports GPEI and urges all member states to do what is necessary to free the world from wild and vaccine-derived polioviruses so that no child will be paralyzed from the vaccine-preventable disease. The United States notes that the operation, management, and security challenges facing GPEI prior to the pandemic remain, and returning to the pre-COVID status quo is unlikely to get polio eradication back on track. The new GPEI strategy needs to address risks from a more holistic point of view. The United States urges the GPEI to implement the recommendations from the governance review, including providing a greater role for countries, civil society, humanitarian organizations, and donors in the decision-making process. The United States urges other member states to join us in continuing to support polio transition planning. Finally, the United States would like to thank Mr. Michel Zafran for his tireless efforts in polio and welcome the new polio director, Mr. Aidan O'Leary. We look forward to working with you. Thank you.
Thank you very much, United States of America. May we now give the floor to Bangladesh, to be followed by Australia. Bangladesh, you have the floor.
Update on poliomyelitis eradication, as well as on the implementation of the strategic action plan on polio transition. The world has made remarkable progress to eradicate polio. It is now on the brink of becoming only the second human disease in history to be eradicated. In this regard, we commend the concerned efforts made by the governments, WHO Global Polio Eradication Initiative, Gavi, and other relevant partners and donors to reach this point. Mr. Chair, we understand that the COVID-19 pandemic has significantly disrupted the work of combating vaccine-preventable diseases, including poliomyelitis. Therefore, it would be crucial now to repair immunization systems affected by the pandemic through mobilizing adequate funds and resources. We also recognize the valuable contributions of polio workers to COVID-19 response. Whatever the situation is, we must continue to push to rid the world of all forms of polio, close the immunity gap, and contribute towards universal health coverage. Bangladesh was certified polio-free in 2014. As one of the 16 priority countries, we are working towards implementation of the Polio Transition Plan, dividing it into 3 phases. However, funding remains a key challenge and obstacle to implementing this plan. Mr. Chair, in light of the working documents and taking into account of our own experiences, we wish to underline a few points. First, efforts should be continued to implement appropriate immunization and surveillance strategies, including through environmental surveillance, as to complement AFP surveillance. Second, the emergency preparedness and response plan should include the provision of responding to any outbreak of poliovirus of any origin. Third, effective collaboration between the government and the partners and donors would be key to ensure the required resource mobilization and capacity building. And finally, Mr. Chair, WHO should consider facilitating vaccine manufacturers of developing countries to produce BOPV and IPV. Thank you, Mr. Chair.
Thank you very much. And now to Australia, to be followed by Germany. Australia, you have the floor.
Thank you. Australia thanks the Secretariat for the reports on polio eradication and transition planning and commends the Global Polio Eradication Initiative for using the polio program's infrastructure to support the global COVID-19 response. We recognise the COVID-19 pandemic has had far-reaching impacts on the polio program, and the GPEI and its partners are working hard to re-establish momentum on polio immunisation in remaining endemic countries. We acknowledge the ongoing role that GPEI will have in supporting the delivery of COVID-19 health interventions, including vaccinations. It is more crucial than ever to accelerate the integration of the functions of the polio program into other health programs, as outlined in the Polio Endgame Strategy 2019 to 2023. The rollout of COVID-19 vaccines provides an opportunity for GPEI and its partners to accelerate integration and progress multiple health outcomes at the global, regional and national levels. So, we support the GPEI's interim program of work's focus on the interface between immunisation and other primary healthcare services and surveillance systems, and in the strengthening of immunisation programs. We highly support the implementation of the integrated public health teams in WHO country offices, bringing together the polio, emergencies and immunisation expertise and building on the strong polio footprint. Strengthening country capacities for immunisation programs is essential, and we welcome further information on the stand-up of these teams. Such integration should inform resource reprioritisation in GPEI, noting also the forward outlook in the resource envelope available to GPEI. Australia would also like to thank Michel Zafran for his commitment and leadership of the polio program over the past 5 years, and to welcome Aidan O'Leary to this role. We look forward to continuing to work closely with GPEI to eradicate polio. Thank you.
Thank you. And now to Germany.
Germany thanks the Director General for the reports on polio. Germany notices with concern, like others, the polio surge in Afghanistan and Pakistan, as well as the worsening situation of vaccine-derived poliovirus in outbreak countries and the dropping immunization rate caused by the halt of vaccination campaigns in the context of COVID-19. We urge GPI to support national governments to put polio back on the emergency agenda while seizing the opportunity for a systematic approach to integrated PHC actions in order to strengthen national health systems more broadly. It does need strong political support and leadership combined with sustainable health financing to put resilient health systems in place. Also, all actors and programs must be harmonized and aligned. Therefore, integration of polio assets, well-prepared transition plans, and above all, country ownership from government as well as civil society are of greatest importance when discussing the GPI strategy revision as well as the interim program of work on integration. Integrated activities are one important key to success for polio eradication. In some areas, they are the only approach viable. Germany would like to underline the importance of the latest Independent Monitoring Board report on how to better address both polio eradication as well as polio integration. We are looking forward to seeing these recommendations addressed. Two important processes are currently underway: the revision of the GPI strategy and the governance review. Especially regarding the latter, we would have welcomed a notion in this report on the way forward with regards to implementation. Last but not least, we share the concern with regard to the financial gap of GPI's budget in this year. The way forward is looking for new financial resources, but also focusing on increasing efficiency. Thank you.
Thank you, Germany. And now to Sudan, to be followed by Kenya. Sudan, you have the floor.
Thank you, Chair. Chairman, the member states of the Eastern Mediterranean region are deeply concerned by the persistent risks associated with the international spread of wild and vaccine-derived polio viruses. New outbreaks of circulating vaccine-derived polio viruses, in particular type 2 outbreaks in the region, represent a deepening emergency. Regrettably, the effort to eradicate polio has been severely impacted by the COVID-19 global pandemic. Disruptions to planned supplementary immunization activities against polio, coupled with a pause in essential health services, including routine immunization, has allowed the virus to thrive. Member states pledged to enhance our regional commitment to polio eradication through the newly established Regional Subcommittee on Polio Eradication and Outbreaks, and to use this forum to fully support Afghanistan and Pakistan to stop wild polio transmission, intensify efforts to close outbreaks of vaccine-derived polioviruses, and prevent further outbreaks by improving immunity of all children to polio and enhancing surveillance activities. The member states of the region recognize the commitment of member states to end transmission of all polioviruses evident in the responses to outbreaks, including most recently in Somalia, Sudan, Yemen, and Iran. Welcome the emergency use listing of the novel oral polio vaccine type 2 to control the outbreaks in the region, and request the Director General to provide member states the necessary assistance to expedite national processes to enable the importation and use of the vaccine. Recognize the growing threat of both measles and polio outbreaks during COVID-19 and the WHO and UNICEF joint emergency call to action for measles and polio outbreak prevention and response announced by the Director General at the end of 2020, and commit to strengthening immunization systems in order to respond to this threat. Recognize the role of polio eradication assets in the response to the COVID-19 pandemic, and commit to maintaining focus on the urgent tasks of eradicating polio, while providing continued support to the next phase of the COVID-19 response. Commit to polio transition activities that ensure continuation of polio essential functions through their integration into national health systems and public programs. Without reservation, the member states of the East Mediterranean region reaffirm our collective will to achieve global polio eradication and to bequeath to the world of polio-free future. I thank you, Chair.
Thank you. And now to Kenya, to be followed by China. Kenya, you have the floor.
Thank you, Chair. Kenya aligns a statement with that made by Burkina Faso on behalf of the African member states. We thank the Director General for presenting the reports on poliomyelitis eradication, polio transition planning, and polio post-certification. Kenya is implementing routine polio vaccination and polio eradication activities in line with the Polio Eradication and Endgame Strategic Plan 2019 to 2023. Kenya was certified polio-free by the World Health Organization in 2005, but risks of importation of the vaccine-derived poliovirus type 2 into the country remains high from the neighboring countries where outbreaks continue to be reported. Kenya is undertaking a series of requisite activities to prepare for the introduction of the novel oral polio vaccine type 2 in the event that we encounter an outbreak of circulating vaccine-derived poliovirus 2 in the country. It is worth noting that the ongoing COVID-19 pandemic has significantly disrupted routine immunization services, including polio vaccination activities, and may threaten some of the achievements of the vaccine program. Despite this, Kenya continues to strengthen surveillance and response activities for polio, as well as other vaccine-preventable diseases, including measles, neonatal tetanus, bacterial meningitis, among others. Chair, Kenya thanks the Global Polio Eradication Initiative for their continued efforts to rid the world of polio. We urge all stakeholders to continue supporting their work through mobilizing resources to sustain polio eradication activities. In keeping with the spirit of leaving no one behind, it's critical that we reach all children in hard-to-reach areas so as to enhance vaccine coverage in those regions. Finally, Chair, whereas Kenya is not among the 16 priority countries being supported by WHO to develop national plans for the implementation of the Strategic Action Plan on Polio Transmission, we support the integration of polio eradication initiative activities into national health systems as the pathway towards successful transition. In that regard, Kenya has conducted in-country mapping for the existing polio assets and capacities as part of polio transition planning. I thank you, Chair.
Thank you. And now to China, to be followed by the Russian Federation.
Chair, China thanks the Secretariat for the report on polio eradication, transition planning, and post-certification. As mentioned in the report, the world has achieved significant progress in polio eradication, and only 2 countries report local transmission of wild polio virus. African, Southeast Asian, and Middle East countries are undertaking actions for global polio transition, and all countries are facing huge challenges in eradication and transition in the context of COVID-19. China responds actively to WHO's call and implements the eradication plan. In order to contribute to the global efforts, China introduced in 2019 2-dose IPV in its national immunization plan, and its immunization strategy includes 2-dose IPV and 2-dose bivalent OPV. It also works actively in containment. China supports WHO's efforts in polio eradication, and China hopes WHO takes fully into account the situation of developing countries, especially those with high risk of imported cases, when suggesting practical and feasible activities, strengthens cross-country and cross-region cooperation to reduce the global transmission of the wild virus, increases financial and technical support to countries with or at the risk of polio transmission, and takes measures more rapidly and effectively in key regions to accelerate the global eradication. Thank you, Chair.
Thank you. And now to the Russian Federation, to be followed by Indonesia. Just confirming that the Russian Federation would have the floor. Thank you.
Thank you very much, Chairman. Chairman, the Russian delegation would like to thank the Secretariat for having prepared the reports. We note, however, that despite all the efforts that have been put in to stopping transmission of wild poliovirus type 1 and measures taken to react to outbreaks of circulating vaccine-derived virus type 2, outbreaks of polio are spreading. This situation has been caused above all by pauses in routine immunization programs and a lack of properly effective reaction to outbreaks which have occurred, particularly in the course of the COVID-19 pandemic. Together with measures to ensure general access to vaccines, we think that it's also necessary to bring in and make wide use in this emergency situation of the novel oral polio vaccine type 2. That would make it possible to bring down the risk of the appearance of vaccine-derived viruses in circulation. Serious breaks in immunization campaigns and other measures taken to protect the health of the population as the result of the COVID-19 pandemic have shown how necessary it is to take a coordinated and comprehensive approach to this situation. Using the strategy of the Global Polio Eradication Initiative, together with other health programs in the course of the pandemic, has been shown to be effective. It has guaranteed a rational approach to the use of both human and material resources in the interests of the population's health. Questions of containment, as far as we are concerned, are key in the Global Initiatives program, and we think work needs to be continued on strengthening the technical potential of countries and on preparing national audits. We also think that it would be appropriate for the WHO Secretariat to think further about the question of providing all relevant institutions and laboratories in those countries which are planning to stop using wild polio virus alternative genetically stable poliovirus strains, while clearly defining the areas in which they can be used, for example, for the production of vaccines or for scientific research. Furthermore, we would also like to see WHO review the issue of the financial, technical, and material support that it could give to laboratory networks in countries. And here I'm thinking particularly about the provision of reagents when I talk about material support. I'm also talking about countries where poliomyelitis is not endemic. The absence or weakening of this kind of support could have a very negative impact on surveillance in those countries. Thank you for your attention.
Thank you. And now to Indonesia, to be followed by the United Kingdom.
Thank you, Chair, and thank you to the WHO Secretariat in preparing the report under the agenda item. We would like to reiterate our appreciation to the WHO for supporting Indonesia during the CPDPV1 outbreak in Indonesia. The outbreak is a lesson learned on how we need to strengthen our polio immunization and surveillance system. We have done so, and it's not limited to the affected area, but also in other provinces at risk. Indonesia upholds its commitment to support all efforts towards the achievement of global polio eradication goal and fully agrees that routine immunization improvement is very critical to prevent and stop outbreaks, leading to a world free from polio. Following this commitment, Indonesia is also committed to join the global effort to make the urgently needed polio vaccine available to support the polio eradication goal. Regarding the polio transition plan, Indonesia, in collaboration with related stakeholders and partners, identified and mapped the required resources to support the transition plan by utilizing it to strengthen immunization program and other PPD surveillance system. High-level commitment is crucial to translate this plan into action. Considering the risk of wild poliovirus importation and the emergence of vaccine-derived poliovirus, as well as the disruption of the immunization program during the pandemic, Indonesia supports the extension of the polio endgame plan 2019 to 2023. To sustain polio eradication, we agreed on the importance of robust improvement of routine immunization and vaccine-preventable disease surveillance, including laboratory examination capacities. We also agree that all activities aimed at sustaining polio eradication should be integrated in the Immunization Agenda 2040. Moreover, strong collaboration with other health system units and continuing support from partners are important to achieve and maintain polio-free status. Thank you, Chair.
Thank you. And now to the United Kingdom, to be followed by India.
The UK welcomes the reports. Eradicating polio remains an important priority for us, strongly linked to our focus on global health security. Firstly, we are grateful to those member states who have responded to the joint call for emergency action to prioritise polio in national budgets and mobilise additional urgently needed resources. To address the critical resource gap, we urge all member states to respond and for GPEI to increase its focus on efficiencies. Regarding the report on eradication, we would have liked to see more comments on GPEI adopting a stronger risk management approach per discussions of the Polio Oversight Board, as well as on the July 2020 GPEI governance review and a commitment to addressing its recommendations. Furthermore, we asked the Secretariat to provide more information on the GPEI strategy revision, which is due by the end of March, and we request that a full draft is shared with GPEI donors for comment. Please could the Secretariat also clarify what will be presented to the WHA and whether this will be for approval or for information only. We also encourage the DG to address the recommendations of the most recent report of the Independent Monitoring Board, particularly in the COVID-19 context. We recognise progress that countries have made towards transition planning and acknowledge the particularly challenging conditions of the past year. However, we are concerned at the slow pace with which polio transition plans are being finalised. Given current funding constraints, this work needs to be expedited now more than ever. Finally, we look forward to receiving the Transition Independent Monitoring Board's report and encourage the DG to work with the TIMB to take forward their recommendations. Thank you.
Thank you very much. And now to India.
For almost a decade now, India has dedicatedly worked towards sustaining its polio-free status, and this was made possible due to the leadership and commitment of Government of India with support from state government, WHO National Polio Surveillance Project, and other key partners and donors. India will continue maintaining optimum coverage of polio vaccine in routine immunization system as well as at international borders with special focus on 8 high-risk countries. Chair, India conduct 1 nationwide and 2 sub-nation pulse polio campaign to maintain high population immunity against polio as per recommendation of India Expert Advisory Group on Polio. COVID-19 pandemic adversely affected essential health services like immunization and supplementary immunization activities such as pulse polio campaign due to increased involvement of frontline workforce in COVID-19 pandemic mitigation measures. However, India issued several advisories to streamline routine immunization, polio SIA, and surveillance-related activities with focus on COVID-19 appropriate behavior to minimize the risks of resurgence of polio and other vaccine-preventable diseases. Chair, with Global Polio Eradication Initiative as the major contributor, WHO NPSP, while initially focused exclusively on polio eradication, gradually expanded its activities to include support for routine immunization and measles and rubella elimination. Furthermore, NPSP has been at the forefront of the country's response to COVID-19 pandemic in terms of strengthening surveillance, demarcating containment zones and other buffer zones, tracing contact of confirmed cases, strengthening quarantine center, and capacity building of human resources. However, India is in the list of low priority countries for Global Polio Eradication Initiative support as the interest of donor has reduced in polio infrastructure in view of declining trend of polio worldwide. This has led to decline in commitment funding support for WHO and PSC over the year. Chair, India believes that global funding from GPEI for polio and NPSP should continue as a global challenges are still there for all the countries, especially when high numbers of wild polio virus type 1 and type 2 cases are getting reported. It is important for us to sustain the gains made so far in polio eradication and immunization program. Thank you.
Thank you very much. We shall now move to those member states not represented on the board. I should wish to invite the distinguished delegate of the Philippines to be followed by Canada. Thank you, Philippines. You have the floor.
The Philippines declared a polio outbreak in 2019 due to the detection of vaccine-derived poliovirus, both in environmental and human samples. A national comprehensive outbreak response was conducted to avert poliovirus transmission through the conduct of several rounds of synchronized polio outbreak response immunization activities using both monovalent OPV type 2 and bivalent oral polio vaccines, and through heightened AFP and environmental surveillance. The COVID-19 pandemic significantly disrupted immunization activities, especially in areas with documented COVID-19 community transmission. Caregivers were not bringing their children to health facilities. Human resources handling the immunization and surveillance activities were diverted to COVID-19 efforts, and other health service providers were also infected with the disease. An integrated nationwide supplemental immunization activity was conducted in phases to mitigate the effects of the pandemic on the delivery of immunization service and to minimize the risk of SARS-CoV-2 transmission during vaccination sessions. We combined the delivery of measles rubella vaccine with the bivalent oral polio vaccine, while at the same time ensuring that vaccinators, vaccinees, caregivers, and support personnel are protected from the COVID-19 infection. The country conveys its gratitude to the WHO and the UNICEF for their unwavering support to the country's polio response, and for WHO's acknowledgement of the Philippines' response to the outbreaks of circulating vaccine-derived poliovirus type 1 and type 2 in the midst of the pandemic. Thank you.
And now to Canada, to be followed by Monaco.
Merci, Madame Modératrice.
Thank you, Moderator. Canada, welcomes the IMAP for resuming campaigns before the end of 2020 and the protocols put in place to protect health workers and health institutions. Canada reiterates its commitment to the eradication of polio, both the wild strains and the vaccine-derived strains. Canada congratulates the African continent on its certification vis-à-vis wild poliovirus. We remain nevertheless concerned given the increasing number of cases of wild poliomyelitis and vaccine-derived poliomyelitis. And obviously it's necessary to pursue the vaccination campaigns to stamp out new current outbreaks. Prevention campaigns must not be put off and their value should not be underestimated. Canada encourages IMAP partners to follow the recommendations of the 19th report of the committee and to move forward quickly and define integrated models for service provision. In the integrated program that I mentioned, Canada asks IMAC managers to show transparency given vis-à-vis their commitments and their implementation strategies. We welcome with satisfaction the inclusion in the normal budget of the essential functions of public health provided for by the Eradication program. This is necessary to prevent, to prepare, and to intervene in the case of epidemic outbreaks in the future, and will open the way towards a full-fledged transition of responsibilities of the Eradication program we continue to urge member states to react rapidly to health emergencies that have been exacerbated by the COVID-19 pandemic and to include their responses in national budgets. And this includes, obviously, outbreaks of poliomyelitis. We would like to thank, as others have, the WHO for its efforts to eliminate poliomyelitis. Many thanks.
Merci beaucoup, Canada.
Thank you, Canada.
And Monaco, vous avez...
Monaco, you have the floor now. Thank you, Mr. President. First, big thanks to Dr. Mizal Zafran for his passion and his untiring work. Obviously, we are very pleased to see Dr. Larry, with whom we will be working with great pleasure. The reports that have been put forth by the Executive Board have led us to various conclusions. First, the poliomyelitis, the virus strain, continues. We're seeing more and more outbreaks, and we're seeing, obviously, vaccine-derived outbreaks as well. And this puts in jeopardy the eradication of the virus. A new oral vaccine would allow us to reduce these risks. That's one thing. Second, we need to pick up or go back to vaccination campaigns, and this for all children and all diseases that could be prevented by vaccination. That's obviously, financing is insufficient, and we've have to suspend or slow down vaccination campaigns because of this. The new IMEP strategy presented in May at the WHO should allow us to get around this risk. Let's talk about the transition now. COVID-19 has showed that it's necessary to intensify all efforts to integrate national health systems while preserving the efforts of eradication centers. You need to use the financial resources as best as possible and even to look for new sources of financing. Monaco continues to be committed in this area, and obviously I have to pay tribute to the work of the staff who are operating under very difficult circumstances. Thank you.
Thank you. And now to Zambia, to be followed by Norway.
Thank you. Zambia will limit the intervention to poliomyelitis eradication, item 15.1. Zambia aligns the statement to that of Burkina Faso delivered on behalf of the Africa region and commends WHO and all stakeholders on the strides made thus far towards the eradication of polio and the efforts made by the member states in our region to attain certification of Africa region as free from wild poliovirus. Chairperson, the continued outbreaks of polio due to circulating vaccine-derived poliovirus type 2, 20 years after the eradication of the wild type, is, however, unacceptable and a reminder of the inequalities that continue to exist in our world. When Zambia last detected a case in 2019 in a patient with no history of vaccination with OPV, it raised alarm as to the presence of CVDPV2 in the environment. Chairperson, it is a daunting task to win people's trust when they learn that the cause of the disease is the best choice we have at its prevention and impact negatively and the fight against the ever-increasing vaccine hesitance. While we acknowledge the Global Polio Eradication Initiative Strategy for Control of CVDPV2 2020-2021, We would be pleased to know to what extent the strategy has been implemented as of today and how widely available has been the novel oral polio vaccine type 2, NOPV2, which has demonstrated a lower risk of mutating and causing paralysis. We believe lessons have been learned from the switch and that in future, adequate alternatives would be put in place, particularly for countries in the low and middle income countries. I thank you, Chair.
Thank you very much, Zambia. And just before we do move to Norway to be followed by Brazil, we would just wish to provide an update that the team are still working to rectify this technical issue. We understand that member states are still not able to raise their hands in the platform, and we thank you very much. Evidently, a number of you have been in touch with the Secretariat indicating that you should wish to take the floor. We would kindly ask that you continue to do so, and we will continue taking those requests and moving through them. Thank you once again for your understanding and patience. That being said, we shall now give the floor to Norway to be followed by Brazil. Norway, you have the floor.
Thank you. Ladies and gentlemen, due to the COVID-19 pandemic, many countries have been unable to maintain the childhood vaccination against polio and other diseases. At the same time, the use of polio resources in the COVID situation has given a unique possibility to show how polio resources can be used in public health, integration, surveillance, and outbreak control. This experience should be used in the transition planning and implementation. The establishment of integrated public health teams, where emergency polio and vaccination expertise work together in the country offices, is an important step forward, which also shows how important the expertise of the polio groups is in many other situations. At the same time, polio transition is strongly linked to the integrational goal of the polio endgame strategy of the global polio eradication. And polio transition planning and operationalization must happen alongside the polio eradication activities. The Polio Secretariat is working on the necessary changes in the financing plans to achieve integration of the polio transition into the public health and emergency plans, including modified plans for reduction or moving of polio funding and staff withdrawal to ensure that national systems are strengthened as necessary. The COVID pandemic has shown the importance of integral public health response measures and may have given a welcomed push forward for transitioning the know-how and resources from polio into the broader public health response. Thank you.
Thank you very much. And now to Brazil.
Thank you, Madam Moderator. Just trying to unmute. Thank you. Mr. Chair, Brazil thanks WHO for the reports on polio eradication, transition planning, and post-certification. We commend the certification of the African region as free of wild polio viruses. Brazil shares the concern with the impact of COVID-19 on the efforts against vaccine-preventable diseases, including poliomyelitis. We encourage WHO, member states, and international partners to do their best to protect and resume immunization programs, thus preventing setbacks on the health gains achieved in the last years. On the work in polio transition planning and polio post-certification, Brazil welcomes the planning for mainstreaming and integrating polio structures into national health structures and health programs. We also appreciate the information about the mobilization of polio networks for preparedness against COVID-19. Thank you.
Thank you very much. And now to EB member Chile. Chile, you have the floor.
Thank you, Chair. Can you hear me?
Indeed, we can.
We're very grateful for an updated report on the situation in respect of poliomyelitis eradication. I've taken note of the information in the report, and we are extremely willing to continue with our commitment to contribute to ongoing global efforts to eradicate poliomyelitis once and for all. We are, of course, aware of the impact that the COVID pandemic has had on the continuity of response to and control of poliomyelitis, and we know that routine immunization campaigns have had to be paused in many countries. Furthermore, resources have been redirected in order to tackle COVID-19. We remain, however, optimistic that many countries will be able to resume their immunization campaigns, and we're pleased at the new strategy to respond to outbreaks of wild poliovirus type 1 and vaccine-derived type 2. We look forward to the full eradication of polio worldwide. Thank you.
Thank you very much, Chile. We have now reached the end of our list of member states who have informed the Secretariat that they should wish to take the floor. We've just had some very brief discussions here in the room, and we understand that normally under this agenda item, we would hear also from countries including Afghanistan, Pakistan, Nigeria. So if we may suggest now that we shall try to give you the floor, should you wish to take it, and we shall proceed from there. Thank you very much. And now, Afghanistan, you have the floor. It would seem not to be the case. May we therefore see whether Pakistan should like to take the floor. Thank you, and Pakistan, you have the floor.
Thank you, Madam Chair. I'm sorry for this technical hitch where I was unable to express my interest. Thank you, Chair. First of all, polio eradication remains a top priority of the government of Pakistan. And under the umbrella of the National Network of Emergency Operation Centers, measures are in place to provide fullest support to the program in accessing each and every household through strong coordination mechanisms at all levels. Mr. Chair, learning from the challenges in 2019, we started our battle afresh through a transformed program in 2020, promoting sense of collective responsibility across all divides. COVID-19 pause did affect our momentum, but we took a consensus decision to repurpose the polio program's strengths and capacities in surveillance, risk assessment, and communication in support of our ongoing COVID response. These contributions have indeed been instrumental in our success thus far. However, we did not lose our focus on our primary goal. Our top leadership, committed managers, and valiant frontline workers decided to tackle both major public health emergencies of polio and COVID simultaneously and with full force. Since July 20, besides supporting essential immunization, our program pivoted to resume door-to-door campaigns, ensuring all requisite protective measures. Since then, we have conducted 7 successful polio campaigns in various scopes, using different types of polio vaccines to deal with the dual outbreak of wild and vaccine-derived polio viruses. Mr. Chairman, in 2021, Pakistan polio program is in better shape with a good control on virus transmission. We shall build on these gains, and with the generous support from the GPEI, donors, and partners, our team aims to interrupt transmission of vaccine-derived polio virus by the end of current low transmission season and wild polio virus by the next, inshallah. In the context of transition, COVID-19 pandemic has demonstrated the opportunity and strong ability of the polio program for the cross-programmatic integration and collaboration. Pakistan plans to capitalize on this growing momentum to further expand its partnership and build on the strong polio footprint to strengthen essential immunization and integrated public health service delivery to achieve our broader goal of universal health coverage. I thank you all.
Thank you very much, Pakistan. May we now inquire whether Nigeria should wish to take the floor. Nigeria, you have the floor.
Okay. Can I get you on this number?
A distinguished delegate from Nigeria, just confirming that you would have the floor should you wish to make an intervention. Thank you. As it seems not to be the case at this time, we shall now give the floor to the Republic of Korea. Republic of Korea, you have the floor.
For the WHO headquarters, regional offices, member state, and global polio eradication initiative for their efforts toward the eradication and sustainable transition of the polio, even in the impact of COVID-19 on international polio responses. Despite the unprecedented challenge presented by the COVID-19 pandemic, polio vaccination programs were conducted with the protection of field health workers and physical distancing in close alignment with other vaccine programs of WHO and UNICEF. And also, staffs have utilized their experience and knowledge from combating polio virus to support COVID-19 responses. The integration among the programs and close cooperation with national authorities shown in this process have presented significant potential in the direction of the polio eradication and transition. Furthermore, the introduction of novel oral polio vaccine type 2 conducted by WHO and GPEI will contribute significantly to efforts for polio eradication. The Republic of Korea has maintained the polio-free condition through polio surveillance system, national immunization program, and polio containment process. Moreover, for international transition prevention, we have implemented inbound passenger surveillance and traveler management and NIP coverage for immigrant children. Furthermore, the Republic of Korea is operating national certification committee composed by KDCA and expert group to supervise the transition process, and the committee submits an annual report to the Western Pacific Regional Polio Certification Commission. The Republic of Korea recognized the crucial importance of closer collaboration among member states and polio program stakeholders, and will continue our efforts to support WHO and other member states to ensure stable polio eradication and transition and effective COVID-19 responses. I thank you for your attention.
Thank you very much to the Republic of Korea and to all member states who have spoken thus far under this agenda item. As I understand that we have received no further requests to take the floor at this stage, through the chair, we would wish to now move to those statements by non-state actors in official relations with WHO. And we've just been informed, again, bear with us, that Gavi, the Global Vaccine Alliance, would wish to take the floor. With that, Gavi, you have the floor. Thank you very much. Thank you.
Thank you for helping us, helping facilitate the dialogue today, despite the technical challenges. Now, getting to the Gavi statement, to achieve and maintain a world free of wild and vaccine-derived poliovirus, our collective efforts must prioritize restoring and sustaining comprehensive and equitable routine immunization coverage to the zero-dose and missed communities. It is absolutely essential that this ambition also be incorporated into the new GPEI strategy currently being developed. With this in view, Gavi calls upon member states to redouble efforts to develop comprehensive, contextually appropriate integrated service delivery strategies of essential immunization and primary health care, including VPD surveillance, community engagement, and outbreak response measures that strengthen components of routine immunization systems. Furthermore, we ask member states to accelerate discussions related to the transition of polio essential functions into national systems, leveraging the experience and expertise of polio-funded assets to strengthen routine immunization coverage and the delivery of life-saving vaccines, including polio vaccines. I thank you, Chair.
Thank you very much to the representative of Gavi for this statement. We have just been informed that Japan should also wish to take the floor on this agenda item. Therefore, before we do move to those non-state actors in official relations, may we kindly invite the distinguished delegate of Japan to take the floor. Thank you.
Thank you, Chair. Japan appreciates the report submitted by the Secretariat. We also thank the WHO for advancing the global polio eradication program during the unprecedented COVID-19 pandemic. We welcome programmatic linkages established with a special program on primary healthcare, as the capacity that exists through the polio network can support the strengthening of primary healthcare in priority countries. We are concerned that cases of wild polio virus type 1 in Pakistan and Afghanistan has been expanded to areas where the epidemic was free, and that the response to outbreaks of circulating vaccine-derived poliovirus type 2 has been inadequate. Due to geopolitical factors, conflicts, and population migration, further strengthening of vaccine measures considering the local context is necessary. Moreover, Japan would like to raise 3 points. First, health systems, including surveillance, have been affected by the COVID-19 pandemic, and we are concerned that the number of reported cases may not reflect the actual situation. Second, further consideration of operational aspects to deliver vaccines is necessary, such as how to implement vaccination campaigns effectively during the COVID-19 pandemic. Third, in this regard, Japan expects the WHO to accelerate collaboration with immunization partners, including Gavi, to strengthen strategy, monitoring, financing, and advocacy. I thank you, Chair.
Thank you very much indeed, Japan. We shall now move to those non-state actors in official relations with WHO, noting that the speakers list follows the order in which the statements were submitted. And with permission from the chair, I would like to invite the representative of the United Nations Foundation. UNF, you have the floor.
Yes. The United Nations Foundation remains fully committed to global polio eradication, as well as critical polio integration and transition efforts. We commend the GPEI for its efforts to balance continued progress on polio eradication while ensuring that polio-funded assets remain available to aid countries in their response to COVID-19. The COVID-19 pandemic continues to impact immunization coverage for all vaccine-preventable diseases, including polio. Countries that are experiencing outbreaks of polio, measles, and other vaccine-preventable diseases amidst COVID-19 are being especially hard hit. We ask leaders to fully support health systems and frontline health workers in their efforts to sustain essential health services, such as immunization, during the pandemic. We urge leaders to fully support the recent joint call to action on polio and measles outbreak response, as a disturbing number of children around the world are at increasing risk of preventable illnesses and death. We hope that the cooperation between polio and measles and other immunization programs will continue. As health systems are increasingly strained due to COVID-19, there is an important opportunity for polio and other immunization programs to maximize synergies and integrate where possible. Thank you, Chair. Thank you, Moderator.
Thank you very much. And now to the representative of Rotary International. Rotary, you have the floor.
Thank you, Chair. Rotary International welcomes the update on polio eradication. In spite of the pandemic, we continue to mark milestones. Last August, the wild polio virus was certified eradicated from the Africa region. We look to build on this success in Pakistan and Afghanistan. Access to children remains challenging due to the COVID-19 related pause in polio activities and due to conflict and political instability. Negotiating access and offering other essential services to these children is difficult, but essential. Pakistan responded to COVID-19 with a whole of government approach we'd like to see translated at all levels into effective polio program execution. We remain concerned by outbreaks of vaccine-derived polio resulting from low levels of routine immunization, worsened by pandemic-related service disruptions. We urge countries to work to optimize immunization activities while addressing the pandemic response. We welcome the introduction of the novel oral polio vaccine and encourage countries experiencing outbreaks to take advantage of this powerful new tool. We are proud that the polio infrastructure has contributed to the pandemic response through surveillance, contact tracing, and community education, and will likely continue as the vaccine is distributed. We have met and overcome acute and chronic challenges. We must leverage this expertise to achieve and secure eradication by increasing collaboration with other stakeholders who are working to provide equitable access to essential health services. We look forward to the updated strategy, noting that continued investment in polio eradication is essential and value added. We acknowledge governments who share this commitment, noting the new, expedited, or increased funding from Canada, the United Kingdom, the United States of America, and Germany. We also urge governments to prioritize polio and immunization systems in national budgets. Victory over polio remains within reach. Let's remain united and ambitious in our resolve to end polio forever. Thank you, Chair.
Thank you very much indeed to Rotary International. We shall now invite the representative of Medicus Mundi International. You have the floor.
Thank you, Madam Moderator. This MMI statement is supported by the People's Health Movement. The polio transition timeframe is unrealistic due to the pandemic's disruption of vaccination and should be extended and used to revive primary healthcare systems. Many LMIC's COVID-19 response relied on the polio workforce. Countries should invest in strong health systems with sufficient workforce instead of relying on repurposing during crises. After transitioning, polio budgets must be invested in a strong and regularized frontline health workforce and integrated immunization as well as public health surveillance. Integrated public health teams must cover the entire range of health functions, including NCDs, be resourced at community, subnational, and national levels, and include communities in decision-making. The lack of technology transfer and intellectual property sharing, which are needed for scaling up local production of the new IPV vaccine, have reduced the availability of an effective tool against polio. Eradicating polio means eradicating the social, political, and environmental conditions of its spread, including access to water and sanitation, inequality, and conflict situations. Thank you.
Thank you very much to all of our non-state actors and other partners. As there are no further requests to take the floor, I shall hand back to His Excellency, to Dr. Harsh Vardhan. Thank you. You have the floor.
Thank you. If there are no more requests for the floor, I shall ask the Secretariat to respond to the questions raised. Secretariat, you have the floor, please.
Thank you very much, Your Excellency, for giving us the floor. We will respond together with Dr. O'Leary to the issues and questions raised. And first, I give the floor to Dr. O'Leary, who will address issues in relation to polio eradication, and then I will follow up with some issues raised in connection with polio transition. Over to you, Dr. O'Leary.
Thank you, Chair, DG, DDG, friends and colleagues. Many thanks for these warm words of welcome. I am newly arrived to WHO at the start of the year, but not new to the polio program, having worked with UNICEF and in Pakistan for between 2015 and 2017. It's very good to see so many friends on the call. In 2020, we celebrated the certification of the African region as wild polio free, which is a major milestone on the road to global eradication and gives us fresh momentum for the two major programmatic challenges we're facing at the beginning of 2021. Firstly, the interruption of transmission of polio virus in the last two remaining polio endemic countries Afghanistan, and Pakistan. For 2020, there have been 140 cases recorded to date, 38 of which were recorded in the past 6 months. Since the resumed World Health Assembly in November, the resumption of vaccination campaigns in Pakistan and Afghanistan and in neighbouring countries has continued apace. The overall recovery of the programme in Pakistan from the setbacks recorded in 2019 and 2020 is commendable, as the Independent Monitoring Board noted in its latest report. Nonetheless, there are still many critical barriers to be overcome and systematically worked through to achieve our desired goal of 0 cases of polio. The establishment of the EMRO Ministerial Regional Subcommittee on Polio Eradication and Outbreaks to focus on these critical barriers is an important step forward. Secondly, the public health emergency of circulating vaccine-derived polio outbreaks continues, requiring accelerated action. These outbreaks impacted 3 of our WHO's 6 regions in 2020, with almost 1,000 cases recorded, but 30% of these emergencies actually stopped during the course of the year. Thus, we know from experience that it is possible to stop outbreaks even during a pandemic, and we now have an additional tool available to help us with that task. In November, WHO issued its first emergency use license on November the 13th for initial use of novel polio vaccine type 2, just as effective as MOPV2 in stopping outbreaks, but which data demonstrates is more genetically stable. We will continue to work very closely with SAGE to meet all the assurance requirements for the safe rollout of this new vaccine. We expect that over 15 countries will have met the readiness criteria for NOPV2 use this year, should they be facing a VDPV2 detection that requires response. We currently have a stockpile of almost 29 million doses, complemented by additional stocks of monovalent OPV2 available for countries as needed. However, vaccines are only part of the solution. In order to stop outbreaks, vaccines must reach all vulnerable children, particularly those most vulnerable in the hardest to reach areas, the zero-dose children, through a rapid and robust response complemented by strong surveillance. And maintaining this high immunity through routine immunization will help to prevent outbreaks ever happening as we move forward. As we move into 2021, the Global Polio Eradication Initiative is focusing on a number of areas to ensure improved performance to achieve our shared goal. We are revising all aspects of the GPI strategy, management and governance arrangements to identify and fill any gap in its design and its implementation that could either prevent us from reaching 0 or to help us to expedite reaching 0 cases of polio. I would like to thank all member states and stakeholders for both their participation and their inputs, which will continue and intensify until we finalize the strategy by the end of the first quarter of 2021, with a view to presentation at the World Health Assembly in May of this year. The significant disruptions to immunization and health services caused by the COVID pandemic have highlighted the urgent need for more coordinated and integrated approaches, as demonstrated by the role of the polio network in the COVID-19 response. We are working more closely than ever with the immunization and emergencies programs to ensure a successful resumption of all immunization activities and to prepare for and respond to health emergencies. Acceleration of cross-programmatic integration will make polio gains sustainable, paving the way for a successful transition. Polio staff and assets, which have supported the response to the COVID pandemic throughout 2020, will continue to support COVID-19 vaccine introduction and delivery in 2021. We are also working on ensuring a sound financial position. Resuming campaigns and the response to outbreaks have increased the financial resources needed in spite of some savings made in 2020. I would like to take this opportunity to thank GPI donors who, despite the global economic crisis, have continued to ensure and provide the necessary resources, including by responding to the call for action for polio and measles outbreaks. This must be complemented by domestic resources, and we urge polio-affected member states to contribute domestic resources to polio eradication. We cannot and must not lose sight of our shared goal of a polio-free world in what is a critical year for the polio eradication initiative. Together with our partners at Rotary, CDC, UNICEF, the Bill and Melinda Gates Foundation, and Gavi, we shall ensure that our drive to achieve and sustain zero continues through these unprecedented and challenging times. Thank you.
Thank you very much, Dr. O'Leary. And now let me address some issues in relation to polio transition, and let me reassure member states that polio transition remains a corporate priority for WHO in line with the guidance that we received from you in previous governing bodies and also today in the EB. 2020 was a challenging year, but I'd like to reassure you that we remain on track on our key objectives, and we made progress in each of the three priority regions, EMRO, CEARO, and AFRO. The experience of COVID-19 has further underscored the importance of our mission, namely polio eradication and polio transition are twin goals, and their success is critical to strengthening the broader health agenda. We know that we need to make progress and succeed in both. The pandemic has brought unprecedented challenges, but also new opportunities for the polio transition. And let me highlight three of them. Firstly, COVID-19 is accelerating programmatic integration, which is one of the objectives of the polio transition. We are now leveraging our full technical expertise to align polio transition activities with other programmatic priorities and the planning processes. We are regularly monitoring progress through a joint corporate work plan. We are also setting up integrated public health teams, bringing together the expertise of polio emergencies and immunization in the priority countries, linking it also to primary health care. Secondly, COVID-19 has once again demonstrated the value of the polio network, especially at the community level. In all the countries prioritized for polio transition, polio assets were quickly mobilized to provide support to COVID-19 response efforts. WHO has comprehensively documented these contributions, which make a strong case for sustaining the polio network. The polio assets will play an equally important role in supporting the countries for the rollout of the COVID-19 vaccine. Thirdly, COVID-19 underlines the importance and the need for strong and resilient health systems. In countries where there is a strong polio footprint, the polio network is a core component of the essential public health workforce. Polio workers have the expertise, agility, and trust of the communities they serve, and decades of experience working in the most vulnerable parts of the world. As we continue our focus on polio, both to reach and to sustain eradication, we also have a clear vision for the future of the polio asset. It is based on a broad and holistic view, focusing on strengthening immunization, emergency preparedness, country resilience, and primary health care. Country progress remains our focus. In the coming months, we will keep the momentum on achieving the objectives of the strategic action plan, especially at the country level. There were some specific questions asked from the member states, particularly a question from Australia, about the integrated public health teams. As I said, they bring together the expertise in polio, emergencies, and immunization, and they build on the strong polio footprint to serve the broader public health. Initially, they work on COVID and also rolling out the COVID vaccine, but in the second phase, on the post-COVID recovery and resilience, including immunization and primary health care. And in each of the regions, they complement and strengthen the collaboration that already exists on the ground. The second question was about how polio transition fits with the broader immunization agenda. I would like to reassure member states that the 3 priorities of the polio transition and the 7 key strategic objectives of the immunization agenda are fully interlinked, and they are intended to support the stronger health system to tackle multiple diseases. And then the final question was about health financing, financing of the polio transition. And here I would like to reassure member states that we are fully cognizant of the need for the financial challenges to implement the polio transition plans and the need for long-term financing to sustain polio assets. We would like to ensure that this remains a priority for WHO Program Budget 22-23 and beyond. The draft budget presented to the EB reflects our commitment to sustainable financing for the polio network, and we are working closely with GPI and other development partners to develop comprehensive resource mobilization effort for future financing. Finally, we are advocating for domestic funding with the priority countries, which will be the most feasible long-term solution for sustainable financing for the polio assets. And then United Kingdom asked about the country support. That is our plan. We are moving country by country, and by the time we get to the World Health Assembly, we will bring back more information to you, and also in the information session that we plan to organize prior to the World Health Assembly. With this, Chair, I would like to give the floor back to the moderator.
Thank you very much, Dr. Jacob, Deputy Director General. We understand that 2 of our regional directors, the Regional Director for Africa and the Regional Director for the Eastern Mediterranean regions, should also like to provide some inputs under this agenda item. Just before we do cross to RDAFRO and to RDMRO, we have just been informed, the Secretariat, that Costa Rica would also wish to take the floor. So hence would beg your indulgence that we shall first hear from Costa Rica, and then we shall hear from our esteemed regional directors. Thank you. And now, distinguished delegate from Costa Rica, you have the floor.
Just good morning. I thought that Costa Rica was in the afternoon. I'm sorry, we didn't have a request for the floor.
Thank you. With apologies, we had been informed that Costa Rica would wish to take the floor. We look forward to hearing from you this afternoon in that case. May we now invite the Regional Director for Africa, Dr. Moeshi, you have the floor. Thank you.
Thank you very much, Chair and the moderator. Dear Chairperson, my WHO Afro colleagues and I were honored and excited to be part of the joyful celebration by our member states and the Global Polio Eradication Initiative partners of the historic achievement last year of the certification of regional interruption of wild polio virus. Decades of hard work by governments, partners, communities, and frontline health workers made this momentous global health milestone possible. To finish polio once and for all, we are supporting the response to outbreaks of circulating vaccine-derived poliovirus type 2 that have affected 20 African countries since 2018. These outbreak response activities were paused in the context of the COVID-19 pandemic, but since resuming last July, more than 40 million children have been reached and transmission appears to be slowing. I'd like to thank the governments and partners for having responded to our call to innovate, adjust, and restart campaigns. I'm hopeful that with strong outbreak response efforts and the additional tool of the novel oral poliovirus vaccine type 2, we can end all forms of polio in the African region. Regarding polio transition, it will be very important to ensure that the understandable and inevitable shift in resources is managed in a way that sustains the tremendous achievements made. The polio program's contribution to other health programs has been significant and continues, and these contributions highlight the interconnectedness of the triple billion pillars and the importance of working in integrated ways going forward. This is reinforced in the context of the COVID-19 pandemic. For example, we know that 2 of the 3 polio personnel at the national and district levels in our country offices in the region are spending more than half of their time on the COVID-19 response. We see the polio team's contribution across the triple billion pillars. In relation to universal health coverage, the program's unparalleled footprint serves as an entry point to increasing access to immunization, deworming, and treatment for diarrhea, particularly in rural and hard-to-reach communities. On Pillar 2, on emergency preparedness and response, polio colleagues are the main frontline workers in our region responding to outbreaks of cholera, yellow fever, and meningitis. And on Pillar 3, the polio team's capacities to reach underserved communities have been leveraged to deliver micronutrient supplements and messaging on iodization of salt and the determinants of health. In the African region, we intend to sustain these contributions in addition to sustaining polio certification activities like surveillance. Our restructuring of the regional office as part of our regional and now the global transformation program and the implementation of the functional reviews of country offices will facilitate this. The polio program has been unique in how it has innovated, and these innovations, like the use of geographic information systems, are serving many programs in our region. I'd like to add that the rigor with which the performance of the polio program and of its personnel has been assessed provide lessons in accountability, which has been a key theme of the Executive Board discussions this week. We will use the polio experience to inform our improvement of accountability across our work in the region. Having understood the contributions of the polio program, we are convinced that polio transition is a good investment as it will deliver on outcomes related to universal health coverage, health security, and health promotion, including the COVID-19 vaccine delivery. We encourage partners who are interested in achieving strong outcomes across the triple billion pillars to continue investing and working with us in supporting polio transition in the region, even as we encourage our member states also to invest in it. I thank you very much, Chair.
Thank you very much, Dr. Moeti, Regional Director for Africa. May we now give the floor to Dr. El Mandari, Regional Director for the Eastern Mediterranean. Thank you. You have the floor.
Thank you very much, Madam Coordinator. I'm going to give my statement in Arabic. سيد الرئيس أصحاب المعالي والسعادة المدير العام الوفود
Chairman, Your Excellencies, Director General, ladies and gentlemen.
بعد عام حافل بالتحديات الصحية العامة فهو عام 2021 يقلب لنا بصيص
After a year that has been full of public health challenges, 2021 is beginning with a glimpse of light at the end of the tunnel. Many countries in the EMRA region have now resumed their activities immunizing against poliomyelitis, and as you know, those campaigns suffered
سرايته دون رادع في
very
أفغانستان
badly
وباكستان.
from the impact of the
كما أن سريان
COVID-19 pandemic.
الفاشيات
They were
الجديدة
broken off for quite some
لفيروسات شلل
months.
الأطفال
That's
المشتقة من
part of the
اللقاحات،
reason why
لا
wild
سيما فاشيات
poliovirus
النمط
type
2
1 has
في إقليم
started
شرق
circulating
المتوسط
again in Afghanistan
شكل
and
حالة
Pakistan,
طوارئ متفاقمة.
and we have detected
كما
new
أزلت
cases
الفيروسات
of
المشتقة من
transmission
اللقاحات من شبكة
of
المجاري في بلدان شملت مصر
circulating
وجمهورية إيران الإسلامية.
vaccine-derived poliovirus type
مما
2 as well.
يبرز خطر الانتشار
Egypt
الدولي
and the
للفيروس
Islamic
للدول الأعضاء
Republic of
الأخرى،
Iran
ولا سيما
have
البلدان
both
التي
seen new
يتكرر فيها
outbreaks
انتقال
of the
السكان من البلدان
vaccine-derived
المصابة وإليها.
poliovirus type
إن
2.
هذه
For these
حقبة لم
reasons, it's
يسبق لها
essential
مثيل
to
في
step
الصحة
up
العامة،
surveillance so that we can
وربما هي
detect
أصعب
cases
مرحلة
which
واجهتها
might
جهود
lead
استئصال شلل
to
الأطفال.
outbreaks and
ومع هذا
cause
نجحت الخطوط الأمامية
to be
لاستئصال شلل
exported across
الأطفال
borders.
بالتكيف مع التحديات الرئيسية التي
This is one of the
واجهتها
most difficult
وتغلبت
periods
عليها.
that we have
قد
had
تعلمنا من
to cope
الأشهر
with.
الاثني عشر
But
الماضية
despite all the
دروسا قيمة.
difficulties and despite all the obstacles,
وبعد
countries
توقف
are
دام
still
4
putting
أشهر
in the effort to
أنفت
eradicate
حملات التمنيع
poliomyelitis.
ضد شلل الأطفال.
We've learned some
ومنذ
very
ذلك
important
الحين
lessons. As I said, after a
تلقى ما
break of
يقرب من
several months,
66
we've
مليون طفل في
resumed
الإقليم
our
جرعة
efforts
واحدة على
to
الأقل من
immunize
لقاح
against
شلل
polio.
الأطفال من خلال أنشطة التمنيع
66
التكميلي،
million children have been
وهذا أمر
immunized in the
مثير
Emerald
للإعجاب في
region
خضم الجائحة.
as a result of renewed
وينبغي
routine
لنا أيضا
immunization
الإشادة
campaigns
بزملائنا
and
لطريقتهم في تحويل
complementary
تركيزهم إلى
immunization
كوفيد-19
campaigns. I think,
من
given the
أجل تتبع
circumstances,
السكان الأكثر
that
عرضة
deserves a round
لخطر
of
هذا
applause.
التهديد الجديد
Of
للصحة العامة،
course,
واتخاذ
we
إجراءات
have also
المتابعة
had to
والعزل
take some of the
والاختبار
resources
والتلقيح.
available for immunization
ووجب
to
علينا
help us
دعمهم
with our
لتجديد
efforts
تركيزهم
to
على
control
شلل الأطفال في
COVID-19.
2021
And that
والاستفادة
has
في
led to
الوقت
resource
نفسه
problems.
من دعمهم في المرحلة
We
المقبلة
need
من
more
استجابة
people, we need
كوفيد-19.
more staff, they need
وأما
more
اللجنة
resources if
التوجيهية
they are to
الإقليمية
continue
المعنية
stepped up
بالمرحلة
efforts to control
الانتقالية في شلل
poliomyelitis
الأطفال
and
التي
do
أترأسها،
what needs to be done in order to
وتعكف على
bring the
تكثيف
COVID-19
استراتيجياتنا
pandemic under
الخاصة
control.
بالمرحلة الانتقالية لشلل الأطفال والتنسيق مع الدول الأعضاء لتتلائم مع الوضع المتغير لجائحة كوفيد-19
I am the chairman.
والفرص
We need
المتاحة
further
لبناء برامج
coordination among member
صحية
states so
عامة
that
أكثر تكاملا.
immunization
وإنني أحث الدول
activities
الأعضاء على دعم
can
هذا
go
الإدماج
ahead hand in hand
وحشد
with the
الموارد
efforts to control COVID-19.
مال المرحلة
I
الانتقالية
urge
لشلل
all
الأطفال
member states to
لضمان
do
استئصال
more
شلل الأطفال
to
وتعزيز
bring
وظائف
about
الصحة العامة
coordination,
الأساسية
better
والمستدامة.
coordination and integration
ولا يزال
of
شلل الأطفال يمثل
anti-polio
طارئة صحية
activities
عامة
in
تسبب
primary
قلقا دوليا،
health programs at all
وقد حان
levels.
الوقت لتعزيز
Polio
برنامج شلل الأطفال وحشد الأموال
is still considered an
ومنها الأموال
emergency.
المحلية لكي تظل هذه
And
الآلية
rightly so,
الرائعة
because it
قوية
could
من أجل الصحة العامة والتصدي
become
للجوائح
a major
ولكي يتسنى
international
إدماجها
problem
في
again
خدمات
if we're not
الصحة
careful.
العامة
So
الأوسع
we need
نطاقا
the resources that
في
are
شتى أنحاء
required
الإقليم،
to keep
وقد
the
حان
public
الوقت
health
للحشد والتضامن
situation under
الإقليمي الكامل.
control and make sure
إن
that
تفشي شلل
all
الأطفال
countries
دون
of our
مكافحته في
region
أجزاء
are
من
doing what
أفغانستان
needs to be done
حيث
as it
حضرت
needs to be
حملات
done.
التلقيح قد
This
شكل
requires
أزمة
resource
عاجلة ومتفاقمة،
mobilization across the region.
ونحن نعمل مع جميع
The
الشركاء
situation in
الإقليميين
Afghanistan
والأطراف المعنية لاستعادة
has
فرص الوصول
become
إلى
and
هنا
remains extremely
لإيقاف
difficult, and
الفاشية
because of that
ووقاية
we are
مئات الأطفال
coordinating our
الآخرين
efforts with our partners
وإلا
in the region
سيصابون
and
بالشلل.
outside the region in
وأدعو
order to
الدول
bring
الأعضاء إلى
the
إبقاء
outbreaks
حكمتها
there
وتأثيرها
to an end.
وسلطتها على اللجنة
Same goes for
دون
Pakistan.
الإقليمية المنشأة حديثا لاستئصال شلل الأطفال والفاشيات.
We've got children at
وإنني على
risk of
ثقة
being
بأننا
paralyzed for
قادرون
life, and
جميعا
we must
على
save
العمل
them
معا
from
لجعل
that.
إقليم الشرق المتوسط
That
بل
means
العالم بأسره
intensifying
خاليا
our
من شلل
efforts
الأطفال
as we
في
get
نهاية
close
المطاف.
to the finishing
شكرا
line of
جزيلا
our race to
لكم والسلام
eradicate
عليكم.
poliomyelitis. EMRA will continue to coordinate and step up the efforts our region is making to get rid of polio once and for all. Thank you.
Shukran jazilan, Dr. Al-Mandari, our Regional Director for the Eastern Mediterranean. And just before handing back to the Deputy Director General and indeed to the Director General, the Secretariat has just been informed that Afghanistan would wish to make some remarks. remarks. With that, we have the great pleasure of giving the floor to the distinguished delegate of Afghanistan. Thank you.
Hello, good morning. Can you hear me?
Indeed, we can both hear you and see you. Thank you.
Mr. Chair, the Islamic Republic of Afghanistan welcomes the report of the Secretariat on Polio Eradication Program and appreciates the support of the organization and partners in the struggle for eradication of polio. Polio program has faced setbacks in the past 1 year, despite concerted efforts towards polio eradication, We are not where we wanted to be. The main challenges to the polio program in Afghanistan are inaccessibility for polio supplemental immunization campaigns, missing around 2 million kids, that is 20% of our national target. Suboptimal program quality, mainly in access-compromised areas. Parents' refusal to vaccination and low routine immunization coverage in some key polio-endemic provinces. Last year, 56 confirmed polio cases have been reported, of which around 90% are in the South region and 80% in inaccessible areas under control of Taliban, with full or sometimes partial ban on polio campaigns. Followed by the COVID-19 outbreak, the situation resulted in further spread of the polio virus outside endemic areas of South and East, an emergence of type 2 VDPV in the East region, which is a spillover from the Islamic Republic of Pakistan. Until date, 258 CVDPV2 cases are confirmed in the country. However, the good thing is that we know the bottlenecks and they're not permanent. Despite all these challenges, we decided to resume polio vaccination campaigns. Since the resumption of polio SIAs in the country and following the IHL, the polio program has resumed all age group vaccination in around 30 sites, including at crossing points and cross-border sites between Afghanistan and Pakistan and Afghanistan and Iran, international airports, cities in risk-prone zones, and of returnees with OPV in addition to IPV and measles at UNHCR and IOM centers. In addition to that, we have developed new strategic country plans to address integrated services and immunity gaps in the polio endemic provinces. The plan serves as the country's Plan B in response to the long-standing ban of over 2 years on polio campaigns. Finally, we need solutions to address immunization gaps in inaccessible areas of the country, support of the program donors before the situation gets worsened to pave the way for moving forward towards Eradication Objective 2021, and to further improve the quality of the program and more defining accountability lines at different levels of the program. Thank you, Chair.
Thank you, Afghanistan. Please, we're able to connect with you in the end. Shall I now hand back to Dr. Jacob, Deputy Director General.
Thank you very much, Madam Moderator. And I have the honor to give the floor to Dr. Tedros, Director General of the WHO, for his closing remarks.
Thank you. Thank you, DDG. First of all, I would like to thank Member States for warmly welcoming Aidan O'Leary, our new Director, and also for your appreciation of our outgoing Director, Dr. Michelle Zafran's dedication and commitment and achievement. So welcome, Aidan. And, you know, I would like to ask Member States to give Aidan all the support that he needs, and that's what I believe. And also I'd like to thank you, Member States and other non-state actors, for your engagement today and for your contributions. We share the understanding that polio eradication and transition are equally important targets. As we work toward this eradication, we must think about the future. This is how we will ensure that health systems retain capacity and are strengthened long after polio is ended. Polio will only remain eradicated if these systems are strong, as you know. Over the last year, we have witnessed polio workers supporting governments to fight COVID-19 in the most extraordinary of circumstances. Their contributions to diverse areas of the pandemic response unequivocally prove their value for broader public health. To sustain these assets in the long term, we must progress with transition in tandem. I encourage Member States to implement their transition plans in line with the strategic action plan, including by allocation of domestic resources. This financing is crucial to ensure that health systems are ready to respond to future health emergencies. I additionally encourage partners and donors to continue to support the WHO in order to sustain our core functions where polio infrastructure can make the most impact. These functions are central to reaching the GPW 13 goals of promoting health, keeping the world safe, and serving the vulnerable. I thank again all member states once more for today's fruitful discussion and look forward to update you on progress at the World Health Assembly. Thank you.
Thank you, DG.
Chair, that's it from our side. Back to you. Thank you, Excellency.
Thank you, Dr. Tedros. As I see no more comments, may I take it that the board is ready to note the reports contained in documents EB 148/22 and EB 148/23. I see no objection. The reports are noted. This concludes the board's consideration of items 15.1 and 15.2. Excellencies and distinguished delegates, because of the technological issues that have cropped up, we'll take a 15 minutes break at this stage to sort them out, and we shall come back after 15 minutes and meet again. Welcome back. We shall now consider item 9, antimicrobial resistance. The report by the Director General is contained in document EB 148/11. The board is invited to note the report. In its discussions, it is further invited to provide guidance on accelerating member state implementation of national action plans for combating antimicrobial resistance, including through linkages with plans and financing for universal health coverage and primary health care, and addressing health security challenges, including the COVID-19 response. Also, enhancing feedback from health ministries on the process to review the Codex Code of Practice to minimize and contain foodborne antimicrobial resistance so that the code reflects public health values. The floor is now open for discussion. I would like to request that the Secretariat moderate the discussion on the virtual platform. Secretariat, you may have the floor, please.
Thank you very much, Mr. Chair, and it is a pleasure to see lots of hands raised in the Zoom platform. I understand that the technical glitch faced earlier has since been rectified. Great start. With that, I have the pleasure of inviting the distinguished delegate of the United Kingdom to be followed by the Republic of Korea.
Thank you. The UK congratulates WHO for its work to address the silent pandemic of AMR during the COVID-19 pandemic and encourages sustained action and protected investment from WHO alongside strengthened, equitable tripartite collaboration to preserve antimicrobials as critical infrastructure. We welcome the launch of the Global Leaders Group on AMR and urge expedited efforts to establish and fund the other global governance mechanisms. Separately, we welcome progress made in rolling out the global AMR surveillance system, GLASS. Strengthening AMR surveillance will be critical to fully understanding the increasing global impact of AMR and taking action to address it. We hope more member states will sign up to GLASS and support stewardship efforts by adopting the WHO's Access, Watch and Reserve categorization. We call upon other member states to invest in the AMR Multi-Partner Trust Fund to accelerate implementation of One Health national action plans, with the latest tripartite survey showing that just 27 countries self-report as having national action plans that are being fully implemented. Uncontrollable AMR stands to have similar or worse impact. The UK urges continued monitoring and evaluation of all WHO AMR activities, course correcting and focusing as appropriate according to the greatest public health need. Finally, we thank WHO for their hard work and leadership on this important topic. Thank you.
Thank you very much. And now to the Republic of Korea, to be followed by Tonga.
Thank you, Chair. The Republic of Korea recognizes the need for multi-sectoral cooperation efforts to reduce the emergence and spread of antimicrobial resistance caused by the use of antimicrobial agents in public health, veterinary health, agriculture, food safety, and environmental health. We support recommendations of the WHO strengthening control of AMR under their One Health approach, and also supports the evaluation on the work by the ad hoc Codex Intergovernmental Task Force on Antimicrobial Resistance. The Republic of Korea has been working on setting up antimicrobial stewardship program and roadmap, and making various efforts to raise awareness and understanding of AMR. In human health, the Republic of Korea actively plays a leading role in the WHO Global Antimicrobial Surveillance System and has been sharing information on AMR since 2016. In addition, as a chair of the TFAMR, Korea has been making efforts to make the revised code of practice to minimize and contain antimicrobial resistance adopted as an international standard. Furthermore, we initiated a joint project for a One Health approach, which promotes multi-sectoral collaboration in obtaining scientific evidence and sharing expertise through integrated information in the fight against AMR. Such multi-sectoral collaboration is essential to reducing AMR, which spans human and non-human fields under One Health approach. This project continues to invest in AMR research, inspired by AMR surveillance, the mechanism of resistance, transmission, and spread of AMR across human, animal, environmental health sectors, and the development of new antimicrobial and alternative preventive measures for AMR pathogens. The Republic of Korea will be co-hosting the third high-level consultation and meeting on surveillance of antimicrobial resistance and use for concerted actions with Sweden in April. We will also ready to provide support at the 8th session TFAMR, which will be held in Korea in October this year. And also the 44th Codex Alimentarius Commission to help ensure that the code is revised to incorporate comments of health ministries. In future, the Republic of Korea will cooperate with WHO member states to promote awareness of the importance of antimicrobial resistance management and to facilitate international coordination. I thank you very much.
Thank you. And now to Tonga, to be followed by Austria.
Honorable Chair, Your Excellencies, Moderator, on behalf of His Majesty's Government, the Kingdom of Tonga and the Pacific, we commend the WHO effort to spearhead the global response to AMR and welcomes this report on the progress of the Global Action Plan on AMR. Tonga had identified AMR as one of the priority agenda items in 2016, following a series of infectious disease outbreaks, which has overburdened the country's situation analysis was completed and multi-sectoral meeting convened in 2017 developed the National AMR Plan for Tonga. This commitment is in line with the recommendations of the 68th session of the World Health Assembly in 2015 where all member states committed to developing national plans on AMR within 2 years of full endorsement. Currently, we are one of the few countries in the Pacific that have endorsed and launched its National Action Plan on AMR. Tonga also established a multi-sectoral committee, namely the Tonga National Strategy for Emerging and Infectious Disease Committee, to coordinate country response to AMR. Tonga National AMR Steering Committee is a working committee which implements AMR plan with a monitoring and evaluation framework to track progress of the AMR action plan. Tonga share the same challenges as other developing countries with limited funding, human resources, shortages that are slowing the progress in implementing the National Action Plan. The impact of COVID-19 on AMR in Tonga and other Pacific in terms of both direct impacts and on political attention is currently unclear, as it is variously exerting both upward and downward pressure across the many relevant domains. Most significantly, however, COVID-19 has resulted in leveraging of our IPC program, surveillance and regulatory system. COVID-19 had also presented the opportunity for Tonga to strengthen our public health laboratory system in preparation to respond to future pandemics or future public health emergencies. We have our newly established RT-PCR laboratory, and we thank our development partners for their support. The Pacific is aware of the healthcare system challenges, and implementation will take time. Therefore, we encourage our partners to support our government in accelerating our AMR response plan in line with our National Action Plan. Finally, the Kingdom of Tonga and the Pacific request WHO to better support countries' contextual, tailored manner to address constraints faced by individual countries to support strengthening of the national health system for future public health emergencies. Thank you, Honorable Chair.
Thank you. And now to Austria, to be followed by Tunisia.
Thank you, Mr. Chair. I deliver the statement on behalf of the European Union and its member states. The candidate countries of the Republic of North Macedonia, Montenegro and Albania, the country of the stabilization and association process and potential country of Bosnia and Herzegovina, as well as Ukraine, the Republic of Moldova and Armenia align themselves with this statement. The EU thanks WHO for the continued work on antimicrobial resistance and welcomes the progress made to achieve the 5 objectives of the Global Action Plan, especially during the challenging times of the COVID-19 pandemic. AMR is and remains an urgent issue also in the context of the COVID-19 pandemic. Inevitably, the pandemic has led to increased misuse of antimicrobials and has had a negative impact on the implementation of AMR national action plans in many countries. At the same time, the EU notes that the pandemic has also increased awareness for topics like infection prevention, the development and availability of vaccines, diagnostic tests, and new drugs. The role of the environment and the One Health approach, all these topics are key elements to tackle AMR. The EU advocates for using the increased awareness as an opportunity to reinforce the fight against AMR. We welcome the establishment of the AMR Multi-Partner Trust Fund to support development and implementation of national action plans in low and middle income countries, and the establishment of the Global Leadership Group on AMR to strengthen accountability and global governance. The EU appreciates that the work of the Codex Alimentarius Commission on AMR is underlined in the report from the Secretariat and recognizes that active involvement of ministries of health is crucial to ensure that public health objectives are properly considered and reflected in the Codex work. Nevertheless, the EU is concerned that the Secretariat report is only referring to one of the two documents of the ad hoc task force AMR of Codex Alimentarius. The one on revising the code of practice to minimize and contain foodborne AMR, but is not mentioning the work to develop new guidelines on integrated monitoring and surveillance of AMR. The EU would like to emphasize that as regards content and relevance for public health protection, the two documents are clearly correlating and complement each other. The guidance will provide an important tool to combine data of human and veterinary medicine, agriculture, and environment origin, and practical guidance to implement One Health collaboration. The work of the task force of Codex is complex as it covers public health protection, animal and plant health aspects, a prompt, consistent, and successful conclusion of the complete work of the task force with a level of ambition that corresponds to the AMR threat, strictly following a One Health approach is crucially important in order to avoid the need to prolong the time frame of the task force. The EU also welcomes the establishment of the tripartite Joint Secretariat on AMR to ensure implementation through relevant sectors. We welcome the close collaboration of the tripartite organizations, but highlight the need to strengthen and formalize the collaboration with UNEP in order to ensure a One Health approach. The EU remains committed to responding to the silent pandemic of AMR. Thank you very much, Mr. Chair.
Thank you. And now to Tunisia, followed by Gabon.
Thank you, Mrs. Moderator. Mr. Chair, I'm honored to deliver this statement on behalf of the member states of the Eastern Mediterranean region. We in the region are pleased that 15 of our 22 countries have completed and endorsed their national antimicrobial resistant action plans in line with the implementation of resolutions WHA 725 of 2019 and 68.7 of 2015, considering the challenges faced and the various levels of implementation by different countries. It is remarkable that 21 of our 22 member states are enrolled in the global AMR surveillance system, GLASS, despite the competing pressure of the COVID-19 pandemic. 18 of our countries reported AMR data to the system this year, in spite of all the challenges, reflecting the understanding of countries on the importance of these data to the global community. Countries that are either in crisis or in political instability have more challenges in implementing the AMR agenda due to the weakness and limitation of their healthcare limited microbiology capacity, limited expertise, and limited national funds. Support to adapt of implementation to these contexts is needed. We, the member states of the Eastern Mediterranean region, commit to the implementation of the relevant resolutions and solicit the continued collaboration and support from WHO, international organizations, and partners to implement national AMR plans. Through a coordinated multi-sectoral governance and One Health approach, strengthening laboratory capacity, formulation of policies and legislations, and integration of programs supporting countries to provide quality health services. I thank you.
Thank you. And now to Gabon, to be followed by China.
Je vous remercie.
Thank you.
Monsieur le Président, c'est au nom des 47 États membres de la région africaine.
Chairman, Gabon is honored to take the floor on behalf of the 47 member states of the African region on this item concerning antimicrobial resistance in accordance with resolution WHA 72.5. The African region notes with satisfaction the work done by the Secretariat on this issue since 2019. The report highlights the progress achieved in implementing the Global Action Plan on antimicrobial resistance and the difficulties encountered at the various levels of our organization. We welcome the development of national action plans and the conduct of self-assessment surveys on antimicrobial resistance in many member states of our organization. However, we note with concern the increased threat posed by antimicrobial resistance in the context of the global COVID-19 pandemic. This has implications for the achievement of many of the SDGs and the objectives of the 13th General Programme of Work 2019-2023. To address this situation, it's important to integrate the relevant antimicrobial resistance activities into the COVID-19 response. The African Group supports WHO's leadership in coordinating the global One Health response, as well as the efforts of the tripartite partnership. Chair, antimicrobial resistance, AMR, is a global phenomenon, and its growing prevalence produces induced effects on human and animal health. We'd like to commend the various initiatives and the technical support provided by our regional office in strengthening antimicrobial susceptibility testing in 28 countries of our region. And we're also grateful for the organization of the first commemoration of World Antibiotic Awareness Week, together with the government of Kenya, FAO, OEE, and the African Union Commission in November 2019. In November 2020, the FAO, OIE, WHO partnership also organized the World Antimicrobial Awareness Week under the slogan, Antimicrobials Handle with Care, which is applicable to all sectors. Chairperson, while noting the report prepared by the Secretariat, we'd like to reiterate the need for member states to finalize the process of developing their national action plans and effectively implement them in the context of the One Health process to combat antimicrobial resistance. We underscore the importance of the mobilization of financial resources to help member states in collecting and making available the relevant data on the process to review the Codex Code of Practice with a view to setting priorities for action. WHO should further support member states in the development of a response plan by strengthening the capacity of its country offices. Thank you very much.
Merci, Gabon.
Thank you, Gabon.
To China, to be followed by the Russian Federation.
Mr. Chair, the Chinese delegation appreciates the Secretariat for the report and welcomes the active role it has played in different areas to curb global antimicrobial drug resistance. MR is a global issue of wide concern for governments and societies. We note that countries and regions are actively addressing the threat of antimicrobial drug resistance by developing action plans, by designing self-assessment surveys, and organizing the public awareness weeks and joining the global surveillance system. However, during the COVID-19 pandemic, there are serious challenges on how to continue to promote the AMR activities, especially to use such drugs without specific guidance. China recommends the Secretariat for the guide countries, especially low and middle income countries, on how to prioritize in the context of COVID-19 by providing the best practice guidelines in order to seize the opportunities to integrate primary health services delivery models that are consistent with the COVID-19 response and achieve the integration. China hopes that the Secretary will provide detailed information on the progress of code of conduct on minimizing and containment of foodborne antimicrobial resistance and actively promote the response and transparent discussions. China attaches great importance to participating in the global governance of AMR under the leadership of the WHO, continues providing the rational use of the MR drugs and by actively implementing the national action plans and improve the management norms and disseminate information. Looks forward to work with other countries in solidarity. Thank you, Mr. President.
And now to Russian Federation, followed by Australia.
Distinguished Chairperson, distinguished colleagues, the Russian Federation would like to thank the Director General and the Secretariat for the report, which reflects the main work that has been done under WHO stewardship on this issue of AMR, beginning since 2014. Our country is actively participating in all of the international documents preparations and the events ongoing, and is also committed to the policies for a comprehensive approach, the One Health approach. The government of the Russian Federation has adopted a national plan of action for AMR within the Russian Federation up to 2030 and is implementing it. Also in the country, we have adopted a strategy to increase AMR stewardship in areas of food safety, for example. This is a serious threat to the international health system and to healthcare workers. And during the pandemic, the relevance of this issue has only increased. We need to be careful of the use of different AMR devices. The interpreter apologizes, the sound quality is very poor. In this connection, we believe that it is quite timely to work on this for the near future. Under the conditions of COVID-19, we need to look at increasing prevention, and many sectors are involved in this. There's an importance to have a country-level policy, to have appropriate financial and technical resources to support it, including investment in scientific development and R&D, diagnostics, and the proper use of MR. The interpreter apologizes, the sound quality is very poor. We need to ensure the coverage and addressing this issue in primary health care, and of course in our continued fight against COVID-19. With regard to agenda item 36 and 37, which will determine the approaches for the future, we would like to include an high-level expert council's view on the One Health approach. As was noted in the report of the Director General of the WHO, the Russian Federation is prepared to work in this area. We also thank the Commission under Codex Alimentarius on its report, which was aimed at public health through the One Health approach. We thank you very much for your kind attention. The interpreter apologizes, the sound quality is very poor.
Thank you. And next to Australia, to be followed by Germany.
Thank you. Australia thanks the Director-General for the report on WHO actions on antimicrobial resistance since May 2019. While the COVID-19 pandemic has undoubtedly disrupted planning and ongoing national AMR activities, Australia urges Member States to continue to prioritise AMR to the extent possible. Australia commends the WHO for its ongoing critical work on drug resistance and supporting Member States to implement their national action plans. We stress the importance of close consultation with Member States to progress the global framework for development and stewardship to combat AMR, to ensure ownership of the framework by all. In 2020, Australia released our second national AMR strategy and announced funding to support implementation of key national priorities over the next 4 years. Australia will continue to do our part through implementation of our 2020 strategy by supporting countries in our region through a range of AMR-specific activities and by contributing high-quality data to global and regional surveillance initiatives. We're also pleased to acknowledge Australia's representative on the new Global Leaders Group on AMR, the Honourable Susan Lee MP, Minister for the Environment. In her previous role as Minister for Health, she implemented Australia's first national AMR strategy and is therefore well placed to bring a One Health perspective to this group. Thank you, Chair.
Thank you very much. And on to Germany.
In the fight against AMR, the One Health approach is of highest importance. Therefore, we applaud the many initiatives that are putting the One Health approach in practice at global level. One of these initiatives is the work of the ad hoc task force on AMR of the Codex Alimentarius. It is important that this task force will conclude its work with 2 high-quality documents, preferable soon, but later if needed. Germany welcomes the recent establishment of the One Health Leaders Group and is happy to be represented in this group. We trust that it will keep AMR high on the political agenda. Germany thanks WHO for the important work on priority pathogens and their overviews of the preclinical and clinical pipelines for antimicrobials. We appreciate the WHO pipeline reports. We acknowledge that WHO's efforts present an important contribution to the work of the global AMR R&D hub. In our view, international research and development initiatives like GARD-P are important instruments in the global fight against AMR. They deserve our continued and increased support. Germany welcomed the close cooperation between WHO and GARD-P on COVID-19 and AMR. Global health starts at home. Germany is currently developing a new national antimicrobial resistance strategy, applying a whole of government approach, as well as a whole of society approach, and of course, a One Health approach. The new strategy is planned to be adopted this year, and it will run until 2030. Strengthening the prudent use of antimicrobials to maintain their effectiveness will be a key area of the new German strategy. Thank you.
Thank you very much, Germany. I understand that we have come to the end of this morning's session. Just before handing back to His Excellency, to Mr. Chair, we would just wish to note that when the session resumes, we shall be taking the following EB members who have their hands raised in the Zoom platform: Botswana, United States of America, Chile, Ghana, Argentina, and we shall proceed from there. Thank you very much. And with that, back to the Chair.
Excellencies, distinguished delegates, it is now 1 p.m. Central European Time and time for taking the scheduled 1-hour break. We will reconvene at 2 p.m. Central European Time to resume our discussions. Thank you. Welcome back. I shall hand over the floor to the Secretariat to resume our discussions on antimicrobial resistance. Secretariat, you may have the floor, please.
Thank you, Mr. Chair. May we invite the distinguished delegate of Botswana to be followed by the United States of America. Botswana, you have the floor.
Thank you, Madam Moderator. Botswana aligns with the statement delivered by Gabon on behalf of the WHO Africa member states. Let me start by congratulating the Director General for an excellent report on antimicrobial resistance. Indeed, AMR threatens the achievement of many of the Sustainable Development Goals and objectives. I'm sorry, I think I need to mute my audio. Can you hear me, Moderator?
Actually, we can hear you fine. Thank you very much.
I hear myself. I hear an echo. I'm sorry. Can I start again?
Most certainly.
Hello? It's the same thing.
Should you prefer, Botswana, we can move to the United States of America and we can return to you after.
No, that's fine. Let me go ahead.
Sure, please proceed.
Let me start by congratulating the Director General for an excellent report on antimicrobial resistance. Indeed, AMR threatens the achievement of many of the Sustainable Development Goals and objectives of the 13th General Program of Work 2019 to 2023 in the human and animal health sector. The work done by the WHO to coordinate the global One Health response through the newly established AMR division and its two departments is highly commendable. We have observed that the cross-cutting areas involved in AMR are also pertinent for COVID-19. These include, and are not limited to, health system strengthening, primary health care, communicable diseases, emergency preparedness and response, the environment, water, sanitation and hygiene, and food safety as outlined in the report. These areas in low and middle-income countries like Botswana impact human health and economic development. Though the risk assessment done by the Secretariat found that the pandemic disrupted planned and ongoing national AMR activities, there is room to leverage on the synergies between COVID-19 and AMR in a tangible way. Botswana has a draft national action plan on AMR, which we intend to endorse and implement. Several activities to improve awareness and understanding of AMR through effective communication, education, and training have been conducted. As a country, we need more support to invest in research capacities to generate concrete data on AMR. In times of economic hardship, poor quality AMR are particularly widespread in low and middle income countries, jeopardizing patient safety and leading to treatment failures as cited in the report. As a result, we strengthened the national drug regulatory capacity through the BOMRA, Botswana Medicine Regulating Authority. Regionally, we continue to participate in efforts to strengthen AMR stewardship programs and ensure that first-line antibiotics are available and affordable. The Global Coordination Tripartite Partnership on AMR between the WHO, the FAO, and the OIE is key to ensure the global response to AMR under the One Health spectrum. Lastly, Chair, Botswana proposes that effective sanitation, hygiene, and infection prevention measures practiced throughout the COVID-19 pandemic should be sustained as the norm, as they have averted mortalities and morbidities of other medical conditions. I thank you.
Thank you. And now to the United States of America, to be followed by Chile.
Thank you, Chair. The United States notes the report and acknowledges the difficulty of maintaining this effort while the COVID-19 pandemic response continues. We thank Antimicrobial Resistance Division for their dedication. Despite the importance of accelerating action, member states may face difficulty if asked to update, change, or expand national action plans when the global community implements them due to lack of resources and especially in the current COVID-19 pandemic response environment. The COVID pandemic has affected AMR.
Distinguished delegate from the United States, apologies for the interruption. Actually, the sound quality, we regret to inform you, is not so audible from this end. If I may suggest we move to the next speaker and we shall return to you. Thank you for your understanding. Thank you. And with that, I shall now invite Chile to be followed by Ghana.
Thank you, Chair. Chile agradece al director general.
Chile wishes to thank the Director General for the report and welcomes the strategy on the global action plan on AMR. We have a national plan on AMR with a health focus, and in 2016 we were pioneers in Latin America by drawing up an intersectoral national plan, establishing interministerial commitments to move forward in rolling out the strategy. The national plan on AMR 2017-2020 in Chile contains the same strategic lines as you find in the Global Action Plan. We've made progress in human health and animal health, thanks to the joint work of various governmental agencies in collaboration with academia and the scientific community. Our country has given its commitment to move forward on AMR, and we'll shortly have a new version of the national plan, which will contain actions running through to 2025. We believe that member states should attach a top priority to implementing national plans through intersectoral cooperation. We believe that that's vital for the relevant governance in coordinating animal health, human health, medicines, environmental issues, and focusing on a One Health approach. Universal health coverage and health security, all of these issues in the context of COVID-19 are important. Thank you.
Thank you, and Ghana, you have the floor.
Thank you. Thank you very much. Mr. Chair and the moderator, Ghana supports the statement made by Gabon on behalf of the African region. Ghana congratulates the Secretariat for the comprehensive report, which shows tremendous work in the life of the pandemic. Ghana incorporated the environmental sector into its One Health agenda, taking into consideration the effect of the local waste management on infection. In the area of governance, Ghana's AMR Secretariat and Interministerial Committee of Implementing Agencies has been established with clear terms of reference. Focal persons for the AMR Secretariat and some agencies have been identified to coordinate AMR activities as recommended by the AMR policy and plan. Ghana welcomes the World Health Leadership Group, as well as ongoing work on the independent panel on evidence for action against antimicrobial resistance, and urges that there is an all-inclusive approach to their deliberations, ensuring all voices are heard. Ghana also believes that effective stewardship on AMR depends on quality diagnostics and antimicrobials, and urges that access to these require partnerships that benefits all. Partnerships and collaborations, especially with the Fleming Fund, WHO, and others, remain the bedrock of our progress and win-win programs that are key to our next step. Major gap, however, still exists in implementation.
The interpreters apologize. The sound quality is too poor.
Funding gaps. We hope that the draft on the deployment will support countries in implementation. We thank you.
Thank you. And now to Argentina, to be followed by Indonesia.
Thank you very much indeed, moderator. Thank you, Chair. Argentina takes note of the report. The increasing threat of antimicrobial resistance is one of the greatest current challenges facing public health and threatens progress in modern medicine. With a view to dealing with the underlying causes of AMR in various sectors in a broad and coordinated fashion, particularly connected with human health, animal health, and agriculture, Argentina adopted or established the National Committee for Antimicrobial Resistance Control in 2015. And this is coordinated by the Ministry of Health with the participation of all relevant stakeholders. In 2020, Argentina created the coordinating group for the appropriate use of antimicrobials with a view to going further with measures to combat AMR. And we drew up a project called Working Together to Combat Antimicrobial Resistance with representatives of human health, animal health, plant production, plant health, food production, the food safety sector, environment, PAHO, FAO, and OIE. In spite of lockdowns and quarantine measures as a result of the COVID-19 pandemic, we've carried out online meetings on a regular basis with teams of all of those involved, which have given rise to 7 projects being adopted within the framework of a program of work with the European Union. Finally, recognizing the input of the international cooperation, or the importance of international cooperation, and with the support of PAHO, we're strengthening the work of the CARICOM in the area of collaboration for strengthened detection and vigilance of AMR. This project ran through 2020 and involved a number of activities, many of which had to go online. We focused on strengthening surveillance of AMR in 14 member states of CARICOM, dealing with the issue from the point of view of strengthening capacities to carry out testing, to improve diagnosis, and to analyze and gather more data, and then use the results from laboratories to monitor trends and improve prescriptions. A dozen country laboratories were evaluated in this respect. 10 professionals from Caribbean laboratories were trained in Argentina, and more than 300 professionals from 7 countries were trained in laboratory sampling. 9 countries in the Caribbean received a rapid training for detecting resistance, and 9 laboratories in the region were subject to quality control through the Malbrán Institute of Argentina. Thank you very much indeed.
Thank you. And now Indonesia, to be followed by the United States of America.
Yes. Thank you, Chair. Indonesia thanks to the Secretariat for preparing the background documents under this agenda item. Indonesia also appreciates the work that WHO and all member states have done in ensuring the continuity of AMR control program despite the pandemic. Indonesia took note that during the 2019 and 2020, the glass surveillance data showed that there is an increasing number of antimicrobial resistance for several antibiotics. The current pandemic has also affected the pattern of use of antimicrobial use, particularly antiviral agents. Therefore, Indonesia is committed to strengthen the implementation of the Global Action Plan on AMR
from Indonesia. The sound quality is not so great this end. May we suggest that you try turning off the video to see if that helps to enhance the audio? Thank you for your understanding.
Okay. Can I continue?
Please proceed.
Okay, thank you. Therefore, Indonesia is committed to strengthen the implementation of Global Action Plan on AMR, glass AMR, and other global health policy, as well as commitment related to AMR at national level. The Indonesia translates this commitment through our participation in the glass, antimicrobial consumption, and through the dissemination of information on the rational use of antimicrobial agents and antimicrobial use surveillance to the pharmaceutical distributors and industry. In addition, Indonesia has also incorporated access, watch, and reverse antibiotic classification in its latest guideline on antimicrobial use. Due to the pandemic, Indonesia has also developed the guideline for antimicrobial agent use in COVID-19 patients. This is one of Indonesia's efforts to address the AMR issue during the pandemic, where countries are encouraged to adjust the priority of antimicrobial resistance control program. In this regard, Indonesia would like to underline the importance of the global community to continue prioritizing AMR prevention and control as one of the global health issues that, if not properly controlled, will have adverse effects on the health, social, and even economic sectors. These efforts need a synergized collaboration between WHO, other AMR-related UN agencies, and development partners to further encourage multi-sectoral cooperation and improve the commitment of all stakeholders, be it at the global, regional, or national level. Thank you, Chair.
Thank you. And now to the United States of America, to be followed by Bangladesh.
Thank you, Chair. Hopefully you can hear me. The United States notes the report and acknowledges the difficulty of maintaining this effort while the COVID-19 pandemic response continues. We thank the Antimicrobial Resistance Division for their dedication. Despite the importance of accelerating action, member states may face difficulty if asked to update, change, or expand national action plans when the global community already struggles to implement them due to a lack of resources, and especially in the current COVID-19 pandemic response environment. The COVID-19 pandemic has affected AMR and changed use antibiotics. We will need time to understand the impact of the COVID-19 pandemic on AMR and how best to adapt our efforts and our national action plans to these changes. We would be interested to hear from WHO on how they will address these challenges, expanding the scope of action plans to address AMR moving forward, including lagging financing and linkages between AMR and other appropriate health topics. We suggest member states focus on accelerating the implementation of current national action plans and request WHO to consult with member states on how to get back on track before the next biennial reporting progress is due. The United States is represented at the Codex Alimentarius by the Departments of Health and Agriculture, and believe this joint approach is critical to successful policymaking. Our delegation believes ensuring safe, nutritious food for everyone, everywhere is at its core a public health value. We encourage all delegations to participate actively in discussions, specifically in the Codex and on the Code of Practice during Codex meetings and within the Codex process. These discussions contribute to food safety and facilitate food trade by developing science-based standards, guidelines, and recommendations in a transparent, well-defined procedure for collaboration of Codex standards and texts, which reflect public health values. Thank you very much.
Thank you. Now to Bangladesh, followed by Kenya.
Thank you. We thank the Director General for his report. AMR has become a global public health challenge, both for humans and animals. This silent menace has the potential of rolling back most of our medical and therapeutic successes attained over the ages. Bangladesh appreciates WHO for its efforts to fight the challenge of AMR. We commend WHO, FAO, and OIE for their joint initiative to establish a One Health Global Leaders Group on antimicrobial resistance. We thank the tripartite partners for nominating our Prime Minister as a co-chair of the group. We hope that this group would contribute to addressing this threat through rolling out coordinated global action and collective global governance. We do agree that the COVID-19 pandemic has disrupted national AMR activities. At the same time, we think that it has strengthened some key areas of our health systems, including infection, prevention and control, as well as water and sanitation. Countries should be given due support to sustain these efforts that will eventually help tackle AMR. Mr. Chair, it is encouraging to see that currently 138 countries have a national action plan on AMR. But many countries, particularly the low and middle income countries, are grappling with the challenges of implementing national action plans. These countries should be provided with adequate technical and financial assistance to duly implement their action plans. The surveillance of AMR is a critical priority for benchmarking its status, monitoring the impact of action interventions, and in prioritizing effective evidence-based actions. The multi-sectoral AMR working group in many countries are also not functional because of resources and funding problems, including technical resources to improve their surveillance and participation. Therefore, strengthening technical assistance at the regional as well as global levels continue to be crucial. The EB report reflects that adequate progress has been made towards the establishment of the proposed global health framework to combat AMR. Among other areas, we reiterate our call for the inclusion of promoting affordable existing and new antimicrobial and diagnostic tools in the framework. We take note of the issue related to the process to review the codex practice to minimize and contain foodborne antimicrobial resistance. We strongly feel that countries would need assistance in generating capacity for implementation of the revised code and the surveillance guide once the process is accomplished. To conclude, Mr. Chair, we underscore the need for increased innovation in new antimicrobial resistance, vaccines, and diagnostic tools. Support should be provided to models and delete research and development costs from prices and sales volume and follow the agreed principles of affordability, effectiveness, efficiency, and equity. I thank you.
And now Kenya, followed by India.
Thank you, Chair. Kenya aligns her statement by Gabon on behalf of the African regional member states. Antimicrobial resistance is a significant public health concern that negatively impacts the attainment of many of the Sustainable Development Goals and of objects of 13th General Programs of Work 2019-2023. We therefore acknowledge the resolution of the World Health Assembly 72.5 of the 72nd World Health Assembly and commend the WHO for spearheading the global response to antimicrobial resistance in the human health sector and also coordinating the global One Health response. We also take note of the progress made in the implementation of the Global Action Plan on antimicrobial resistance in the Director General's report, EP 148/11, and recognize the efforts of WHO and the tripartite agencies in laying the foundation for collective One Health monitoring evaluation of global action on AMR. Chairperson, in Kenya, we have an active national AMR program based on the multi-sectoral One Health approach, which is a collaborative effort between the Ministry of Health and Ministry of Agriculture, Livestock and Fisheries. This combined effort prevention and containment of antimicrobial resistance in November 2017. Commemoration of our annual World Antimicrobial Awareness Week in 2019 and 2020, Kenya's enrollment in Global Antimicrobial Resistance and Use Surveillance System, PLUS, and launch of National AMR Surveillance Strategy in November 2018. However, we note that, like in other parts of the world, the ongoing COVID-19 pandemic has disrupted planned and ongoing national antimicrobial resistant activities in Kenya and has spotlighted the impact of infectious disease on human health and economic development. In view of the continued threat of antimicrobial resistance to sustainable and effective response to infectious disease globally, we call upon all member states to their part in preserving the existing novel antimicrobials. Finally, we request WHO to support funding to enable implementation of AMR interventions across all policy actions, and requests WHO and the tripartite partners to work with member states to develop key performance indicators to measure progress on antimicrobial resistant activities. To improve biennial reporting on WHO Assembly Resolution WAH 72.5 and WAH 68.7. I thank you, Chair.
Thank you. And now, India, you have the floor.
Thank you, Mr. Chair and Madam Moderator. Antimicrobial resistance has been an issue of consequence in global healthcare for a while, and India recognizes the efforts by the Executive Board and the World Health Assembly in this area. The Government of India is committed to tackling AMR and has developed its National Action Plan on AMR in alignment with the Global Action Plan, which was officially released in April 2017. The National Action Plan has been developed in consultation with various stakeholders and is key to our progress. The National Action Plan focuses on an integrated One Health approach involving coordination among various sectors at the state, national, and international level, and is being implemented by various ministries. Action is underway to develop subnational action plans on antimicrobial resistance. Various sectors have been involved in AMR containment. However, effective intersectoral coordination remains a challenge. India believes that the FAO, the World Organization for Animal Health, and WHO can facilitate intersectoral coordination for AMR containment at the regional and country level through organizing joint activities and consultations. This must include strengthening knowledge and evidence through surveillance of AMR in humans, food, environment, and animal sectors. This year, GLASS, the Global Antimicrobial Resistance Surveillance System, has been expanded to include surveillance of antibiotic consumption and surveillance of AMR. The challenge is to develop mechanisms of collecting precise and comprehensive data on antibiotic consumption. The critical data on antibiotics manufactured and sold can be made available by control departments of states. However, it's very challenging to collect and collate drug consumption data. It is therefore proposed that we develop a standardized practical methodology for collecting the data on antibiotic consumption. Otherwise, consistent data of different countries uploaded in the vendor is not comparable. Mr. Chair, India proposes that there is a need for development of a global platform for sharing best practices from various countries on implementation of infection prevention and control, antimicrobial stewardship activities, implementation of regulations regarding antimicrobial use, etc. I thank you, Mr. Chair.
Thank you. We shall now move to those member states not represented on the board. I should wish to invite Brazil to be followed by Japan and then Zambia. Brazil, you have the floor.
Thank you, Madam Moderator. Mr. Chair, Brazil takes note of the report on we know the actions undertaken to raise awareness of the science-based approach, including the launch of the One Health Global Leaders Group. Throughout 2020, Brazil has reinforced domestic action in line with the Global Action Plan for Antimicrobial Resistance. We have promoted health workers and the public. We set up a national glass hub. We have conducted further research on AMR with international partners, and we have further developed surveillance capacity. Mr. Chair, AMR has become one of the most discussed topics on this agenda. It has also drawn a great deal of attention in other UN with a myriad of initiatives such as the tripartite secretariat, WHO, FAO, OIE. In Brazil, the collaboration between WHO and other agencies within the United Nations system will be as legitimate and successful as they perform under their respective mandates and are accountable to their respective governing bodies. We also see room for improvements in the way that AMR-related high-level scientific bodies should connect their work, the wealth of needs and context of the member states. Mr. Chair, as recalled in our statement, item 8, access to affordable, safe, efficacious, and quality medicines is a key element in the response to AMR, and as such, should be a prominent aspect of any comprehensive strategy, both at national and international level. In this context, Brazil underlines the relevance of R&D and innovation for the development of antibacterial tools affordable to all. Thank you.
Thank you. And now Japan, followed by Zambia.
Japan appreciates the Secretariat for the report. The world has learned the critical importance of taking measures against infectious diseases from the COVID-19 pandemic. At the same time, we should not forget that AMR is also an urgent health security issue. Japan hosts Tokyo One Health Conference since 2016 to promote AMR response in the Asia-Pacific region. The third conference will take place virtually in February 2021. In addition, we are excited that 2 national institutes of Japan will soon be designated as a WHO collaborating center for AMR. Furthermore, Japan also highlights the importance of research and development on innovative antibiotics, including support to GARDP. Chair, we highly value the establishment of the One Health Global Leaders Group on AMR. We will closely follow the discussion. We hope that WHO, FAO, OIE, and UNEP would enhance their collaboration to promote global AMR response. Japan thanks WHO for its continued AMR activity during this difficult time. I have 3 points raised this week. First, we request WHO to monitor how much difference advocacy and education activities help improve awareness based on evidence. Second, some member states have weak lab capacities, which leads to inaccurate domestic surveillance data for glass. We request WHO to provide technical support to member states in strengthening lab and surveillance capacities to collect quality data. Finally, we expect the WHO to strengthen its encouragement and support to improve appropriate use of antimicrobial drugs. Thank you, Chair. Back to you.
Thank you. And now to Zambia, followed by Thailand.
Thank you, Chair. Zambia aligns this statement to that made by Gabon on behalf of the Africa region and commends Secretariat for the detailed progress report and the efforts highlighted in acting decisively on WHA resolutions 68.2 and 72.5 to address antimicrobial resistance. Chairperson, Zambia, being a member of the Alliance of Champions of AMR, was among the first member states to develop the National Action Plan aligned to the Global Action Plan. Chairperson, drawing from our experiences and the challenges faced with implementation of the National Action, we wish to propose the following. First, member states need to increase investment in clean water, sanitation, and hygiene in healthcare facilities, farms, schools, and in household and community settings, in line with SDG 6, IISC recommendation, and M&E tripartite global action plan for AMR. Second, member states need to strengthen regulation for antimicrobial waste, for the discharge of antimicrobials and waste potentially contaminated with antimicrobials into the environment. This is a new area of commitment. Third, to mobilize financing, particularly for LMICs, the tripartite secretariat's role should include mapping fund streams and assist expansion and implementation of the tripartite trust fund. This will ensure sufficient and sustainable AMR funding. And finally, to help the developing of global vision on AMR, Secretariat should finalize the development and stewardship framework to combat AMR from a One Health approach, and to mobilize both technical and financial support for strengthening veterinarian services and facilitating the transition to more sustainable antibiotic use practices in animal food production for small-scale producers and resource-limited facilities. I thank you, Chair.
Thank you. And now to Thailand, followed by Norway.
Thank you, Chair. Thailand recognizes the effort of the WHO with collaborative partner to tackle AMR. We recognize that COVID has made the challenge to fight AMR even more intense. Therefore, we strongly encourage the WHO to put its higher effort to implement global action plan on AMR. In addition, we would like to highlight two key issues. First, infection prevention and control, or IPC, play a crucial role in the management of COVID-19. It provides an opportunity for the improvement of IPC infrastructure. However, we would like to recommend that antimicrobial stewardship activity should be integrated into the pandemic response across health systems, such as developing local treatment guidelines, optimizing the use of antimicrobial, and providing proper training of health workers. Second, evidence generation can help support the high level of political commitment through critical and reliable information. The tripartite should accelerate the implementation progress of the tripartite integrated surveillance system on AMR and antimicrobial use, which is an initiative for integrating data from the human, animal, plant, food, and environmental sector. Particularly in the environmental sector, there are few international guidelines and standards for surveillance of AMR and AMU. Without a support global mechanism, integration initiative for AMR would be a major challenge at the national level. Thank you, Chair.
And now Norway, to be followed by Canada.
Chair, the reduced attention given to the problem of antimicrobial resistance in the context of COVID-19 risks exacerbating the global crisis of AMR even further. Norway supports the call to accelerate member state implementation of national action plans and the call for linkages with plans of and financing for universal health coverage and primary health care, and addressing health security challenges. Norway strongly supports the call for enhanced feedback from health ministries on the process to review the Codex of Practice to minimize and contain foodborne antimicrobial resistance. The principle of own health necessitates stronger involvement in Codex for ministries of health to prevent further dissemination of antimicrobial resistance from food production. Thank you, Chair.
Thank you. And now to Canada, followed by Malaysia.
Thank you, Chair. Addressing the global burden of antimicrobial resistance continues to be a high priority for Canada, and we are pleased to support the ongoing work of the WHO EB under Resolution WHA 72.5 and WHA 68.7. The COVID-19 pandemic further underscores the importance of high-level global commitment to address this critical issue. We note in particular the UN Research Roadmap for COVID-19 Recovery's urgent call for research to inform action on One Health challenges such as AMR. Canada thanks the WHO, the FAO, and OIE for their progress to date on the implementation of the Global Action Plan on AMR and their continuing efforts to support member states in their implementation and evaluation of multi-sectoral national action plans and related initiatives. We welcome the establishment of the One Health High-Level Expert Council as an important step to further strengthen collaborative work between the tripartite and UNEP. Canada supports collective action on AMR and actively engages in multiple international fora, including the G7, G20, Global Health Security Agenda AMR Action Package, the Global AMR Research and Development Hub, the Joint Programming Initiative on AMR, and the Ad Hoc Codex Intergovernmental Task Force on AMR. Canada's inputs to the discussions for the Codex Task Force include representation from our Department of Health and Public Health Agency. We appreciate opportunities to provide input for the review of the Codex Code of Practices, with the view that public health values should be reflected within the context of the Codex mandate. Domestically, the Government of Canada is contributing to these efforts by collaborating with key partners and stakeholders in implementing the Pan-Canadian Framework for Action, which is aligned with the strategic objectives of the WHO's Global Action Plan. Canada is also working with both government and non-government organizations to expand surveillance systems, strengthen antimicrobial stewardship, and the prudent use of antimicrobials across human and animal sectors, and engage in research and innovation to support these initiatives and develop new products and processes for diagnosis and treatment of resistant infections. We look forward to continuing to work with our international partners on this critical issue. Thank you, Chair.
Thank you. And now Malaysia, followed by the Philippines.
Thank you, Chair. Malaysia reaffirms its commitment for WHO's initiative in regards to combating the increasing prevalence of antimicrobial resistance worldwide, and would like to thank and congratulate WHO for its role in spearheading the global response to AMR in the human health sector and to coordinate the global One Health response. Malaysia also takes note on the report by the WHO on the actions taken at all levels to fight AMR. To ensure concerted effort between agencies in tackling AMR, Malaysia has reviewed the implementation progress of its National Action Plan 2017-2021 annually and has incorporated the AMR in the Malaysia Strategy for Emerging Diseases and Public Health Emergency, MySET2 2017-2021. The MySET2 aims to strengthen public health emergencies preparedness and response capacity by improving core public health systems, increasing regional connectivity and coordination, and investing in ongoing performance improvement. Malaysia has also linked the AMR containment program with the COVID-19 response. For instance, during the World Antimicrobial Awareness Week 2020, health professionals and public have been reminded on the cautious use of antimicrobials during the COVID-19 pandemic. Malaysia, as a member of the Ad Hoc Codex Intergovernmental Task Force on Antimicrobial Resistance, via Health Ministry and Department of Veterinary Services, is working closely to address public health concerns in reviewing the Code of Practice. Malaysia also acknowledges the progress of the document, which has been adopted at Step 5 during Codex Alimentarius Commission 43 meeting in November 2020, and will continuously address public health issues at the upcoming TFAMR 08 meeting in September 2020. Malaysia will continue to stay proactive and committed to WHO's agenda in addressing the growing burden of AMR. Thank you, Chair.
Thank you. And now the Philippines, followed by Sweden.
Thank you, Moderator. The Philippines takes note of the progress in implementing the Global Action Plan on AMR and continues to support this agenda with the implementation of our second Philippine National Action Plan. We are happy to share that the ASEAN Strategic Framework to combat AMR has already been adopted by the health ministers of the ASEAN in August 2020. This framework was developed with the leadership of the Philippines and support from the tripartite. The strategy incorporates the collective input from all relevant sectors across the ASEAN. Mr. Chair, the ongoing pandemic paved the way for the Philippines to revisit our National Action Plan. recognizing the interplay between COVID-19 and AMR. Supply chain disruptions of antibiotics, as well as interruptions in the delivery of routine immunization services, have been experienced in our country due to lockdowns following the emergence of COVID-19. There were also reports of misuse and overuse of antibiotics in managing COVID-19 patients. These developments, if not addressed, can push back all the gains in our fight against infectious diseases. Hence, we have doubled our efforts to promote antimicrobial stewardship, working with our partners in both the human and animal health sectors. With support from the WHO, we developed online courses on antimicrobial stewardship for hospitals and primary care facilities to prevent the worsening of AMR, even as we face the current COVID-19 crisis. The Philippines is grateful for the continued support and leadership of the WHO in advancing the agenda on AMR. We remain committed in sustaining our country efforts, aligned with the Global Action Plan and the common goals shared with other member states to build strong health systems resilient against all health threats. Thank you, Chair.
Thank you. And now to Sweden.
Thank you, Chair. Sweden aligns itself with the statement made by Austria on behalf of the EU and its member states. We welcome the report from the Director General. We are glad to see that some achievements have been possible despite the difficult situation we're in. The pandemic should not make us forget the growing global threat of AMR, quite the opposite. We should make sure to use lessons from the COVID-19 response also in addressing AMR. This includes the rapid development of vaccines, demonstrating the power of science and what can be achieved through collective efforts. The third GLASS report shows that critically important antimicrobial drugs used to treat common infections are becoming ineffective all over the world, and that there are significantly higher rates of resistance in low and lower middle income countries. To support implementation of national action plans in low income countries, we urge other countries to join Sweden in supporting the Multi-Partner Trust Fund for AMR. AMR is a high priority for the Swedish government. We welcome the discussion and emphasize the importance of a One Health approach and transparency in the process of reviewing the Codex Code of Practice to minimize and contain foodborne AMR in line with the Codex Procedural Manual. We encourage our colleagues to engage in next year's final deliberations to enhance feedback from health ministries to ensure that public health values are duly reflected in the Code of Practice. We are proud that Swedish Minister for Health and Social Affairs, Lena Hallengren, has been selected as a member of the Global Leaders Group, and we urge the tripartite to secure sustainable funding for the global governance mechanism. Last, Sweden is proud to host the WHO Collaborating Center for Antimicrobial Containment that support the global AMR surveillance system. This year, Sweden will co-host a third high-level technical consultation and meeting on surveillance of antimicrobial resistance in use for concerted action. GLASS enrolled countries are invited to participate in the digital meeting starting on the 28th of April. Thank you.
Thank you, Sweden. Thank you to all member states. I understand that we have received a number of requests from non-state actors in official relations with WHO to take the floor on this agenda item. The speakers list follows the order in which the statements were submitted. And with that, I should like to invite the representative of the International Alliance of Patients Organizations. IAPO, you have the floor.
Thank you, Chair. Thank you, Moderator. IAPO welcomes the report by the Director General on AMR and congratulates the progress made with setting national policies, surveillance systems, the global coordinating mechanisms, and awareness-raising activities in fighting the AMR. We also thank the Member States and the WHO Secretariat for reinforcing the importance of AMR fight within the patient safety agenda on Thursday. The current pandemic has affected the continuity of antimicrobial stewardship efforts to a yet unknown scale. We believe that patients can and need to play a bigger role in this fight because appropriate antimicrobial use is everybody's business. IAPO urges member states to consider and employ the existing capacity, expertise, and outreach of patient and civil society organizations, in reinforcing the AMR efforts. We are glad to inform that in 2021, IAPO is initiating the AMR Patient Alliance with the aim to bring together patient-led efforts worldwide under a vision of a world where human-induced antimicrobial resistance is eliminated. Our hope is that AMR Patient Alliance will give voice to patients in every member state and also empower them for sustaining the efficacy of antimicrobials for as long as possible, for as many patients as possible. Thank you for your attention.
Thank you. The World Dental Federation, FDI, you have the floor.
On behalf of FDI World Dental Federation, we congratulate WHO's efforts to spearhead the global response to AMR. With dentists prescribing up to 10% of all antibiotics worldwide, they must be involved in tackling AMR. To this end, we strongly urge member states to consult with national dental associations when developing national strategies and action plans, as well as guidelines and prescribing policies on antibiotic use for dentists. The DG's report on oral health noted that oral health services were among the most affected essential health services during the COVID-19 pandemic. Lack of access to timely dental care during lockdown periods led to a dramatic increase in antibiotic prescribing rates, with a 25% increase seen in England alone. Access to dental treatment rather than antibiotics must be a priority to support in efforts to control AMR. Thank you, moderator. Thank you, Chair.
The Global Health Council, GHC, you have the floor.
Thank you, Chair. The DG's report highlights that there is a need for additional financing to strengthen country and regional office capacities to control the emergence and spread of AMR and to invest in global research and development. We call on member states to increase investment and innovation in quality-assured, new and improved antimicrobials, novel compounds, diagnostics, vaccines, and other health technologies to fight AMR. Innovation should be developed with the most vulnerable in mind and be appropriate, affordable, and accessible to all who need them. To increase investment in the clinical development of antimicrobial treatments and diagnostic tools, we also call on WHO, member states, and other stakeholders to advance policies necessary to revitalize discovery and product development, including supporting the Global Antibiotic Research and Development Partnership, GARD-P. We urge WHO to support member states in developing their own national action plans to fight AMR and to provide technical guidance to accelerate their implementation. Lastly, we call on member states to enroll in the Global Antimicrobial Resistance and Use Surveillance System, GLASS, and ensure that surveillance and diagnostic data is shared with WHO. Thank you.
Thank you. The International Federation of Medical Students Associations.
Honorable Chairperson, distinguished delegates, the International Federation of Medical Students Associations, supported by the International Veterinary Students Associations, congratulates the WHO on its achievements toward combating antimicrobial resistance. One of the implications of COVID-19 pandemic has been the disruption in the fight against AMR, which continues to require a strengthened response. Hence, we call upon all member states to ensure adequate professional training and enhanced public awareness on the use of antibiotics. Moreover, we strongly acknowledge the importance of involving future healthcare providers in research, surveillance, and policy formulation as part of the implementation of action plans. And thus, we call upon all stakeholders present to utilize and involve more young people in combating antimicrobial resistance, strengthening interdisciplinary collaborations, and fulfilling the One Health approach. Thank you.
Thank you. The World Medical Association.
Thank you. The COVID-19 pandemic has stressed several issues relevant to AMR. Due to the challenges to fight treatment to COVID-19 patients, antimicrobials were used as direct treatment even when incidents show no benefit. Further antimicrobials were prescribed for possible co-infections, although co-infections are low. Both patterns increase prescribing rates of antimicrobial agents. Additional high transmission of multi-drug resistance organisms due to hospitalized COVID-19 patients and the reduced testing and surveillance of infections through the disruption of healthcare deteriorate the AMR situation. The focus on COVID-19 shifted away funding from AMR. It is crucial to continue and step up the political and financial commitments to AMR globally and nationally now. Furthermore, we would like to highlight the urgent need for a global coordinating mechanism to streamline investment into the development of new antimicrobials, diagnostic and AMR products with a focus on access. Thank you.
Thank you. Medicus Mundi International.
Thank you. This MMI statement is supported by PHM. Progress in national action plans remains slow. Indicators are weak in measuring implementation. Low middle income countries need more technical assistance to improve surveillance system for enrollment in class as well as SDG indicator 3.D.2. Economic reforms that address fiscal constraints on LMIs are required. We are concerned by pharma companies' role in AMR stewardship programs given past bias and unethical marketing practices and their distorting impact on interventions. Higher resistance rates in LMICs despite lower per capita antibiotic use points towards systemic determinants such as poor public health spending, sanitation and IPC and irregulated private health sector. A public sector-led impact investment fund is needed in the face of the limitations of the AMR Action Fund and its narrow focus on late-stage molecules. Preventive and growth-promotive use of antibiotics in animals is not a therapeutic use and should be reflected as in Codex. Thank you.
Thank you. Drugs for Neglected Diseases Initiative.
Thank you. We thank the WHO for the report and its and countries' support to GARD-P to develop new treatments for drug resistance. The growth of drug-resistant infections is a silent pandemic. Left unchecked, humanity will be unable to treat infections. Like COVID-19, drug-resistant bacteria can infect anyone of any age in any country. Unlike COVID, we can prepare now. The drug-resistant microbes are known, and meaningful change can be achieved with political will and resources. Member states can prepare by investing in the development of medical countermeasures, including diagnostics, treatments, and vaccines. Ensuring access for all, including developing new mechanisms to secure access to existing and new treatments. Expanding global cooperation across geographies and sectors. No country or organization can do this alone within a One Health framework, and ensuring low and middle income countries are equal partners in a comprehensive global response. All countries' know-how and capacities must be harnessed. Thank you, Chair.
Thank you. The International Pharmaceutical Students Federation.
Honourable Chair, distinguished delegates, it is a great honour to speak on behalf of the International Pharmaceutical Students Federation, IPSF. AMR is one of the most urgent public health issues affecting future generations. IPSF, along with other healthcare student organisations, held the first ever Global AMR Youth Summit, which highlighted the crucial role of youth and the importance of a coordinated One Health approach against AMR. IPSF urges the WHO and member states to emphasise the education of physicians and pharmacists on the rational use of diagnostic techniques and implement surveillance systems for rational prescribing and dispensing of antimicrobials. Pharmacists play an active role as antimicrobial stewards in de-prescribing and educating the public on the suitable methods of self-care when antimicrobials are not appropriate. IPSF calls on the WHO and member states to create and implement frameworks for interprofessional learning and practice for healthcare students and professionals. We call on the recognition and inclusion of youth and civil society as key stakeholders in creating and implementing the AMR National Action Plans, and to also collaborate with youth representatives to establish, coordinate and support youth engagement programs on all levels. Thank you.
Thank you. World Federation of Societies of Anesthesiologists.
Thank you, Madam Moderator and Mr. Chair. The World Federation of Societies of Anesthesiologists is the foremost global alliance of anesthesiologists providing perioperative and critical care medicine, including infection prevention and control. The surgical site infections are the most common healthcare-associated infections among surgical patients. Widespread misuse and overuse of antimicrobial to prevent and control infections, together with the use of poor quality of microbial in low and middle income countries, increases the risk of antimicrobial resistance. AMR lead to treatment failure, antibiotic-associated adverse outcome, post-operative morbidity, mortality, and higher hospital and healthcare costs. The WFSA calls on member states to adopt two actions. First, that the perioperative use of antibiotics prophylaxis in preventing or treating surgical site infection must be evidence-based to ensure optimal delivery, dosage, and schedulings of the appropriate antibiotics. Second, the recommendation of the WHO model list of essential medicine and the WHO antimicrobial stewardship program in healthcare. Thank you.
Thank you indeed to all non-state actors. Just before we do hand back to His Excellency, to Mr. Chair, we understand that EB member Sudan has just raised its hand and should wish to take the floor. With that, Sudan, you have the floor.
Thank you, Chair. Honorable Chair, distinguished delegates, excellencies. Sudan welcomes the report by the Director General, congratulates the Secretariat on the progress achieved thus far, and commends WHO on the addition of Indicator 3.D.2 to the Sustainable Development Goals to monitor antimicrobial resistance globally. The COVID-19 pandemic has presented potential threats that could affect antimicrobial stewardship activities and drive antimicrobial resistance. Current evidence shows high level of resistance for commonly used antibiotics, as well as high generation cephalosporins. Sudan reported 76.8% prevalence of antimicrobial use as per recent data. Sudan has implemented evidence-based behavioral change intervention project, tailoring antimicrobial programs, creating huge awareness as well as generating evidence as pilot on behavior change for rational use of antibiotics amongst prescribers, pharmacists, and the community. A similar study was implemented amongst farmers, herders, and vets for optimal use of antibiotics. We have also strengthened AMR stewardship and implemented point prevalence surveys to measure the prevalence of antimicrobial use and healthcare-associated infections amongst hospitalized patients and updated the essential medicine list to optimize use of antimicrobial resistance. Sudan enrolled in Global Antimicrobial Surveillance System, GLASS, in 2018, with much improved AMR surveillance. We have also supported and contributed in the development of animal health AMR surveillance and antimicrobial use AMU with FAO and Ministry of Agriculture, and progressed on another integrated tricycle project as a tool to measure the burden of AMR, as well as strengthen integrated AMR surveillance in Sudan. Partnerships are central in the fight against AMR, and as AMR falls within the mandate of many organizations, we call for their coordination at all levels. Sudan emphasizes the importance of and calls for legislation to ensure prevention of antibiotic use by the animal sector. We call for the reactivation of governance structures of AMR in line with One Health approach and enhanced resource mobilization to ensure the progression and sustainability of the AMR agenda, ultimately becoming one step closer to achieving universal health coverage and the health-related sustainable development goal. Thank you.
Thank you, Sudan. As there are no further requests for the floor, I shall hand back to Mr. Chair.
Thank you. If there are no more requests for the floor, I shall ask the Secretariat to respond to the questions raised. Secretariat, you may have the floor again.
Thank you, Mr. Chair. I understand that the Office of the Regional Director for the Americas should wish to respond. With that, we hand over to you. Thank you.
Thank you, Honorable Chair and Madam Moderator.
The region of the Americas has exercised significant global leadership around AMR through its active participation in the One Health Global Leaders Group on AMR, as represented by 4 of our member states: Barbados as a co-chair, Brazil, Canada, and the United States of America. Experts from the region will also be contributing to the newly established Global Strategic Technical Advisory Group on AMR. In the Americas, 34 countries have developed national action plans, and all countries have initiated AMR containment actions. PAHO-AMRO has facilitated the development of multi-sectoral approaches, the provision of solid quality technical cooperation, and the exchange of best practices among the countries and territories of our region. Our nations are advancing in establishing integrated AMR surveillance, monitoring antimicrobial use and consumption, including banning the use of colistin in the animal food production, improving post-market surveillance of antibiotics, and strengthening infection and prevention and control prevention measures, especially in the context of the COVID pandemic. In the spirit of Pan-Americanism and solidarity, cooperation among countries accelerates health development and multiplies results. With PAHO support, Argentina and CARICOM member states have joined forces to improve AMR diagnosis and surveillance in Caribbean countries. PAHO, FAO, and OIE, with support from the European Union, have led innovative interventions in 7 countries of the region, paving the way for integration models for the rest of the region and other parts of the world. To date, at least 10 countries have conceptualized or implemented integrated AMR surveillance through multi-sectoral collaboration. To achieve a One Health approach in tackling AMR, the integration of action across different sectors is fundamental. The tripartite alliance has a critical role to play. Now, despite progress, challenges remain, and let me touch on just some of them briefly. Achieving holistic and multi-sectoral One Health AMR actions, addressing the increase in resistant healthcare associated infections, overcoming the reductions in resources allocated to AMR, and tackling the sensitivities related to the pharmaceutical industry and the food production sector, or some of them. In that regard, the review of the Codex Code of Practice to minimize and contain foodborne antimicrobial resistance requires a clear public health position. Now more than ever, AMR should remain a priority on the political agenda, and all means should be put forward to reduce the burden of infectious diseases and the impact of the COVID-19 pandemic. Thank you. Back over to you, Madam Moderator.
Thank you very much. And with that, I shall hand to Dr. Jacob, our Deputy Director General. Thank you very much. Over to you.
Thank you very much, Madam Moderator, and thank you, Member States, for the excellent discussion and guidance, and the very constructive and positive spirit, and to the strong support to our work. In order to save time, I would like to hand over right away to Hanan Barki, who is the Assistant Director General of Antimicrobial Resistance, to provide her comments, remarks, and reflections. Over to you, Hanan.
Good afternoon, good morning, good evening, everybody. Thank you, DDG. I will be giving my statement in Arabic. شكرا لكم سيدي الرئيس.
Thank you very much. Executive Board members, observers, dear colleagues, I'd like to thank you for your contributions and for your constant support in trying to deal with antimicrobial resistance. And I wish to thank the member states and all participants. In 2020, 130 countries participated in the surveillance system on antimicrobial resistance, and 69 countries have now shared data in this regard. More and more countries are joining the global surveillance system. And data shows that antimicrobial resistance is now an increasing threat. That's why it really is a silent pandemic. So 5 years on, we are trying to update the surveillance system. And we are consulting with all member states, looking into how to do that most successfully. And this will help us to take into account the best data and to make the right public health decisions at the country, regional and global levels. The WHO would like to thank the Republic of Korea and Sweden, who have supported this process. And we wish to thank them for the meeting that was organized and the various measures that have been taken. The meeting is now scheduled for April 2021. And that will be an important event. The surveillance system on the use of antimicrobials and antimicrobial resistance will also share data. And we are looking forward to more countries joining the 10 countries that already participate in the system. And this will be extremely helpful for us in getting the relevant data to enable us to adopt the most appropriate policies for fighting AMR. As I said earlier, this is a silent pandemic that we are facing. And the Secretariat has tried to be very clear about various issues connected with treatment for COVID-19 patients. 134 countries have established national plans in this regard, but a lot of countries lack the necessary financing. And as a result, plans won't have a real impact. We can't be successful if we don't have the necessary financing in place to finance activities at the national, regional, and global level. So we call upon all member states to take the necessary measures to fight AMR by really establishing these national action plans and establishing the financing so that that can be implemented in the context of UHC and primary healthcare strengthening. We have identified a real challenge, and that is that many studies show that 90% of antimicrobials being used are used in primary healthcare centers. And we need a One Health approach. That will be vital in our attempts to fight antimicrobial resistance. And we agree with all member states who said how important it was to support initiatives and integrate AMR measures within the United Nations framework and within the framework of sustainable development. We need to create new governance structures at the global level if we are to fight AMR effectively. And by that I mean this One Health approach. In November 2020, a group was set up to implement One Health effectively. And the Secretariat created an independent panel to look into AMR data, to work hand in hand with other UN agencies. The WHO also bases its work on the GPW13, and the WHO is trying to ensure that countries establish national action plans and trying to support them in those efforts. What we need to do now is focus our efforts within the structure of the triple billion targets. With regard to national action plans, there is a need for technical assistance, of course, for implementation of those plans. And a technical team has been created with expertise in the area of AMR to provide that support. The idea is to move from the planning stage to the implementation stage of these plans. And an institutional mechanism will be set up to provide technical assistance on AMR where needed. The overall objective being to support member states in implementing data-based national action plans. And we call upon member states to adopt the AWARE classification in national plans. And we'd like to thank countries who have done that. That will help us implement the objectives of the plan. 60% of antimicrobials used today are within the access classification, and we need to be sure that quality antimicrobials are being used, because falsified or poor quality antimicrobials are another challenge at global level that needs to be faced. As many of you said, the WHO launched the Secure Initiative, an alliance at global level involving WHO, UNICEF, and other agencies. We also have the Clinton Initiative, which is designed to ensure that patients have access to good quality antimicrobials appropriately. Now, in the context of COVID-19, measures also need to ensure that we limit the impact of COVID-19. And in that context, we of course need to support laboratories in their work and help supply chains, help with ensuring the relevant hygiene and health measures. All of these aspects are important but need to be taken into account in the context of COVID-19. As I said, though, this silent pandemic of AMR began before COVID-19 and will continue to be a scourge after COVID-19. Now, turning to Codex, the code of practice regarding antimicrobial resistance and resistance as a result of food production. We are now in stage 5 of the program, and this will be submitted to Codex, and the proposal will be adopted as a standard, a Codex standard, in the near future. And what's important is to work with experts, ensure that negotiations are successful in helping us to improve the One Health approach. These negotiations need to be ongoing, and bear in mind the framework of Codex. Of course, the WHO supports negotiations on Codex recommendations, in particular regarding surveillance of antimicrobial resistance and foodborne AMR in particular. We're now in stages 2 and 3, preliminary stages of drawing up Codex standards. And with that, I hope to have responded to your various questions, and the Secretariat will also talk to you about the progress that we hope to see in 2021.
Hanan Baki, Assistant Director General, for the extensive response, and particular thanks for the strong support and commitment to the countries, and also the commitment to a strengthened and rebranded multi-sectoral and multi-agency response to the One Health approach, which we are taking forward under the leadership of our Director General. So with this, I am very pleased to pass on to the DG for his concluding remarks.
Thank you, DDG. I think a lot has been said, so I'll be very brief. To support member states with the acceleration of National Action Plan implementation through multi-sectoral One Health coordination and to reach sustainable implementation at national level, I would like to assure you that WHO is committed to scale up support for country implementation coordinated through the 3 levels of the organization. And as you know, through the transformation, there is now better alignment across the 3 lines or 3 levels. Within the context of the pandemic, implementing the relevant programs to mitigate and control AMR, such as infection prevention, surveillance, antimicrobial stewardship, and WASH have become even more crucial. And as we continue to tackle the COVID-19 pandemic, we must simultaneously ensure that efforts to stop the spread of AMR are accelerated to confront this silent tsunami together. And finally, as you know, One Health, the global leadership group for AMR was established last November. And I would like to use this opportunity to thank Her Excellency Sheikh Hasina Wazir, Prime Minister of Bangladesh, and Her Excellency Mia Motley, Prime Minister of Barbados, for their leadership. And thank you also for those who have given us your inputs and guidance today. Thank you so much for your support. Back to you, Chair.
Thank you, Dr. Tedros. As I see no more comments, may I take it that the board is ready to note the report contained in document EB 148/11. I see no objection. The report is noted. This concludes the board's consideration of item 9. We shall now continue our consideration of sub-item 19.3, global strategies and plans of action that are scheduled to expire within 1 year. Following our discussion, we shall consider a draft resolution on the highest attainable standard of health for persons with disabilities as contained in document EB 148/conference/8 and a draft decision on the global health sector strategies on respectively HIV, viral hepatitis and sexually transmitted infections as contained in document EB 148/conference/1. The floor is now open to continue our discussion on this item. I would like to request that the Secretariat moderate the discussion on the virtual platform. Secretariat, you have the floor, please.
Thank you, Mr. Chair. I would like to invite the delegation of Costa Rica to be followed by the Netherlands. Costa Rica, you have the floor.
Muchas gracias, señora moderadora. Costa Rica suscribe.
Thank you very much, moderator. Costa Rica.
Can you hear me?
Yes.
Yes, we can. Please proceed.
Gracias, señora moderadora.
Thank you, moderator.
Costa Rica suscribe la intervención conjunta.
Costa Rica would like to
Mi país tiene el honor de apoyar el proyecto
endorse previous statements and have the honor to support
para promover el acceso de todas las personas con discapacidad en igualdad de
policies
condiciones
to
al más alto
promote
nivel de la salud posible. Y agradecemos
the
a
highest possible attainable level of health for persons with disabilities without
a las
discrimination.
organizaciones representativas de las personas con discapacidad y a la Secretaría por sus esfuerzos para
I'd like to
alcanzar
thank organizations of persons with
A pesar de
disabilities, the
representar un
co-sponsors
millón
of the
de
resolution, and the
personas y de los
Secretariat for what
compromisos
they have done to
adquiridos
come
por
up
la
with this
comunidad
decision and
internacional,
resolution.
tanto a través de la Convención
Despite what has been done by the international community through the Convention on the Rights of Persons with Disabilities and others to achieve the Sustainable Development Goals, people living with a disability, particularly women
y
and
enfrentan
girls,
graves barreras al acceso equitativo a
still
la
face
salud.
serious barriers in the way of getting equitable access to health and health care. Unfortunately, this has been made even more clear by the current COVID-19 pandemic. Costa Rica acknowledges the major efforts being made by the World Health Organization in order to try and meet and guarantee respect for the needs of
Y el
persons
programa
with
global
disabilities,
de
including
cooperación de
quality rights on
tecnologías
mental
de
health
apoyo
and
o
through the
ayudas
Global Program on Assistive
así como las
Technology.
iniciativas para avanzar en el
We should
reconocimiento
also highlight
como parte de los servicios
progress made to include health services for persons
Aunado
with
a estos
disabilities in
esfuerzos,
wider health
es fundamental que
services.
se garantice
It
los
is
derechos de las
fundamental
personas con
alongside this that there be
discapacidad, que
guarantees for the
estos
rights
sean
of persons with
transversalizados
disabilities
en todo el accionar de la
and that
organización.
those be
Por ello, la
taken
importancia
into
de esta
account
iniciativa de
in a
resolución
cross-cutting way in all the
esperamos
work
que
of
se
the
convierta en una
organization.
guía
Hence
para
the importance
avanzar
of
en la
this resolution,
implementación
and we hope it will
efectiva y
help us to make further
transparente de la
progress
Estrategia de
on
Naciones
the
Unidas para la
effective and
inclusión de la
transparent implementation of the UN
así
strategy
como
for the
para
inclusion of
promover
persons with
temas
disabilities.
de cobertura
We also
universal sanitaria
us to include the rights of persons with
de toda la
disabilities
diversidad de personas con
in
discapacidad,
universal health coverage, taking into account the diversity of needs.
Adicionalmente,
Persons with
esperamos que la
disabilities have and
resolución
respect
llame a la
human rights.
reflexión de la
We also
OMS
hope that the
sobre cómo
resolution
abordar
the
programas de
thinking within
prevención
WHO
que
on
estén
how to
basados en un
develop
modelo de derechos
prevention
humanos
programs
con
which are based on the
perspectiva de
human rights
discapacidad.
model, taking
Tarea
into
aún
account
pendiente.
the particular
Todo lo
position of
anterior
persons with
debe realizarse
disabilities.
en estrecha
All this
consulta y
should be done
colaboración
in
con las
close
organizaciones
consultation and
representativas de personas
cooperation
con
with
discapacidad y
representative
asegurando
organizations of
que nadie
persons
se
with
quede atrás.
disabilities.
Finalmente, Costa Rica espera que esta
conclusion,
iniciativa
Costa Rica hopes that
redunde
this
en la inclusión
initiative
efectiva de este grupo de personas en las
effective
campañas de
inclusion of this
vacunación del
particular group of
COVID-19,
people
así como
in
su acceso a
COVID-19
todos los
vaccination
medicamentos y
efforts
tratamientos
and in ensuring
disponibles.
them
Muchas gracias.
equitable access to all the treatment and medicines available. Thank you.
Thank you, Costa Rica. I would now like to invite the delegation of the Netherlands to be followed by Thailand. Netherlands, you have the floor.
Thank you, Chair. As co-sponsor of the resolution on the health for persons with disabilities, the Netherlands aligns with the statement made by Israel. Now we express our support for the draft decision, proposing new global health sector strategies on HIV, viral hepatitis, and sexually transmitted infections. The Netherlands notes in the report that much progress is made in these areas and commends the work of WHO staff in contributing to improved capacities at country level and a high uptake of new guidelines and policies. Though much is accomplished, challenges remain, and much remains to be done to achieve the related SDG targets by 2030. We endorse, therefore, the decision that the WHO develops a new contextualized strategy, a strategy that will be developed in a participatory way, takes into account new scientific evidence, prioritizes actions, and is adapted to different geographic areas and populations, especially key populations, which account in several regions for more than 90% of new HIV infections. The Netherlands is very pleased to hear from Dr. Fauci and his colleagues that the United States will continue its collaboration with WHO, also in the area of HIV/AIDS, and will support policies that improve gender equality and sexual and reproductive health and rights of women and girls. This commitment is very important for a renewed strategy on HIV/AIDS, hepatitis, and STIs. We look forward to work with the US again, as well as with other stakeholders, such as UNAIDS and the Global Fund, in developing this new strategy. Thank you.
Thank you, Netherlands. I now call upon Thailand to be followed by Monaco. Thailand, you have the floor.
Thailand would like to point out 3 concerns leading to the unacceptably slow progress in the implementation of the Global Disability Action Plan. First, health sector too often regards the disability inclusion as the luxury part of the duty. Rehabilitation agenda and persons with disability are literally invisible in the eyes of health sector officials. This is against the concept of universal health coverage. Second, disability inclusion agenda has suffered for long from the compartmentalization. Without coordination across ministries and sectors, disability inclusion is just a dream. Thailand requests the WHO to facilitate knowledge sharing to support multi-sectoral collaboration in disability inclusion. Third, the report confirms the uneven progress in implementation across 6 regions. Unfortunately, the regions with highest demand are having the lowest progress. Next, Chair, we move to the global health sector strategies on HIV, viral hepatitis, and STI. Thailand registers our highest concern on the global phenomenon of antimicrobial resistance of HIV and STI. Multi-drug resistant gonorrhea, for example, is rampant worldwide, leading to limited drug choices for treatment. More than ever, all countries must develop and implement mechanisms for rational use of drugs to address AMR. Last but not least, continuity of HIV, viral hepatitis, and STI services should be ensured during the COVID-19 pandemic and even after, especially for those vulnerable and high-risk populations. Thank you, Chair.
Thank you, Tana. I now call upon Monaco to be followed by Namibia. Monaco, you have the floor.
Good afternoon. The protection of people with disabilities, including an emergency situation, is a priority of the Principality. Monaco finances CWHO's activities in this area or contributed to them. We are co-sponsor of the resolution on people with disabilities. Thank you.
Thank you, Monaco. I would now like to recognize the delegation of Namibia to be followed by Mexico. Namibia, you have the floor.
Thank you, Madam Moderator. Namibia aligns itself with a statement delivered by Madagascar on behalf of the 47 members of the African region. We thank the Director General for his report on the global health sector strategies on respectively HIV, viral hepatitis, and sexually transmitted infections for the period 2016 to 2021, and for the opportunity for member states to consider whether the 3 interlinked global health sector strategies have fulfilled their mandates or need extension or adjustment. Namibia, in its role as chair of the UNA's Program Coordinating Board and co-facilitator of the high-level meeting on HIV/AIDS, together with Australia, is now committed more than ever to the global fight to end HIV by 2030. We have noted with concern that despite considerable progress in key areas of prevention, testing, treatment, and care, the critical interim 2020 targets across all 3 strategies will not be reached. In light of the foregoing, we are of the opinion that WHO should maintain its strategic focus on HIV, hepatitis, and STIs due to the considerable public health challenges posed by these diseases, especially now in the context of new challenges posed by the COVID-19 pandemic. Considering the rationale for the development of new strategies presented by the Director General in the report to bridge the gap between 2022 and 2030, and to ensure that WHO and member states meet our 2030 commitments on eliminating HIV and other communicable diseases as public health threats by 2030, we invite member states to join those that have already done so in co-sponsoring the draft decision on this agenda item. It is our hope that through the development of global health sector strategies on respectively HIV, viral hepatitis, and STIs, we will ensure continued focus for these critical diseases, as combating them is a key component of universal health coverage and health security. Finally, we would like to thank the WHO Secretariat for the invaluable assistance and support in the development of this resolution and the consultations around it. Thank you for your kind attention.
Thank you, Namibia. I would like to call the delegation of Mexico to be followed by Ecuador. Mexico, you have the floor.
Thank you. Building back better and leaving nobody behind means we have to redouble our efforts to improve the health care and health services we provide to people with disabilities. The action plan we are looking at today has laid down the foundations for building on and making further progress, and we appreciate the work put into it by the Secretariat. Today, several countries have plans of action and specific legislation to meet the health needs of persons with disabilities. However, much remains to be done if we are to achieve the original goals of the plan, achieve the SDGs, and make good on the provisions of the UN's Convention on the Rights of Persons with Disability. We cannot forget that 15% of the world's population has a disability of some kind, and many people more have some kind of disability in their lives at some time. It is a fact that persons with disabilities have difficulty in getting access to assistance and rehabilitation. The services which do exist are often not good enough, and the financial problems that many people with disability face means that they can be plunged into poverty. Furthermore, the lack of good quality statistics make it difficult to design good public policy. We are certain that better data collation, the re-inclusion of rehabilitation in universal health coverage, and a clear mandate so that health ministers recognize the inclusion of persons with disability as being part of their central core work are some actions, among others, that will promote achieving the goals of the plan and improve the living quality of this particular group in the population. WHO has an important role to play here. For that reason, Mexico, together with Israel and New Zealand, is promoting the inclusion of the issue on the agenda this year. We hope that the efforts made by and the leadership of Israel will be of assistance, and we have been working together on the draft resolution now presented by her. We hope it will be agreed by consensus and help us to make further progress together. We urge the Secretariat to implement at all levels of the organization the UN strategy for the inclusion of persons with disability. Thank you.
Thank you. I would now like to recognize the delegation of Ecuador to be followed by Canada. Ecuador, you have the floor.
Muchas gracias, señor.
Thank you very much, Chairman. Ecuador is grateful for the submission of the document, which paints us a picture of what is being done to implement the Plan of Action on Disability and deals with the challenges facing member states still in order to ensure that disability and people with disability are properly included in national health policies. In Ecuador, we are particularly seeking to guarantee the rights of persons with disability as a priority through the development of strategies and the taking of action which will ensure that they have equal opportunity throughout their lives and equal access to health care. There are over 150 different units in the Ministry of Health providing care and rehabilitation across the country. We have tried to take preventive rehabilitation and curative rehabilitation. Although we have made headway in the last few years, we agree with the Secretariat document to the effect that thus far there are still important gaps in access to healthcare for persons with disabilities, and where they can have access to healthcare, they're not getting as good a type of care as other people. We should focus on the individual and his or her human rights, and thereby try and ensure better access to healthcare for persons with disabilities and better management of their disability. This will require more investment, particularly in rehabilitation, but not only, of course. We are fully committed to working on this issue, and we are one of the countries which has co-sponsored the resolution. We hope it will be supported and adopted because we think its proposals are fully in line with those included in the UN Convention on the Rights of Persons with Disabilities. Looking at the issue from a human rights point of view, we should be monitoring carefully what is done to implement the UN strategy on the inclusion of persons with disabilities by WHO. Thank you.
Thank you, Ecuador. I would now like to recognize the delegation of Canada to be followed by Zambia. Canada, you have the floor.
Thank you, Chair. Canada thanks the WHO for its continued efforts in developing comprehensive strategies for HIV, viral hepatitis, and sexually transmitted infections. These strategies remain important tools to galvanize action and guide collective efforts. While the COVID-19 pandemic has undoubtedly hindered progress towards the public health elimination of sexually transmitted and blood-borne infections, Canada remains committed to working with member states and partners to achieve global and domestic targets for HIV, viral hepatitis, and sexually transmitted infections by 2030. Canada commends the strong commitment to promoting synergies and integration across the diseases and with programmatic and functional areas of health. This commitment has been the pinnacle of Canada's integrated approach to addressing sexually transmitted and blood-borne infections, and leveraging these efforts will help minimize the health burdens of such diseases in Canada and globally. Looking forward, Canada supports the need to develop new strategies that are reflective of contextual shifts brought on by the COVID-19 pandemic, as well as epidemiological trends, scientific developments, and political commitments, while keeping key populations at the center. We request, however, that all accountability and reporting requirements for these strategies in development be harmonized and aligned with existing mechanisms to minimize additional obligations for member states. Turning to the proposed resolution on the highest attainable standard of health for persons with disabilities, Canada is pleased to be a co-sponsor and wishes to thank Israel for their leadership on this issue. We're happy to note that this year, Canada will be developing its first Disability Inclusion Action Plan, which will include a new disability benefit and robust employment strategy. We welcome hearing best practices from other member states in this respect. In line with these efforts, Canada is committed to upholding and safeguarding the rights of persons with disabilities, ensuring that their access to health and sexual and reproductive health services is free of discrimination, and to removing barriers to enable their full and effective participation and inclusion in society. Thank you, Chair.
Thank you, Canada. I would now like to invite the delegation of Zambia to be followed by Panama. Zambia, you have the floor.
Thank you, Chair. Zambia aligns this statement to that made by Madagascar on behalf of the Africa region and commends Secretariat for the detailed and comprehensive report. Zambia attaches great importance to the needs of persons living with disabilities, the fact that has been exemplified by the development of 2 national action plans, one specifically to address disability needs and the other focusing on palliative care, both of which formed an integral part of the National Health Strategic Plan 2017 to 2021. It is for this reason that Zambia participated fully in the informal consultations on the resolution titled "The Highest Attainable Standard of Health for Persons with Disabilities," and thanks Israel for the leadership in negotiating this important resolution. In joining consensus, however, Zambia wished to re-echo the statement made by Brazil, to which we fully subscribe, that as reference is made to reproductive rights, at no time should abortion be used as a method of family planning. We wish to mention here that Zambia implements robust sexual and reproductive health programs that has seen the country posting gains in both maternal, newborn, and child health and adolescent reproductive health. Chairperson, on HIV, viral hepatitis, and sexually transmitted infections, Zambia has implemented age-tailored interventions to stem the rising incidence of HIV observed in adolescent girls and young women. This situation has been worrying, and we call on multilateral partners to support our efforts, especially with novel interventions such as self-testing. In this regard, Zambia applauds the leadership of Namibia on leading the draft decision contained in document EB 148/conference/1 on this item and supports its adoption. We further request that Zambia be included on the list of co-sponsors. I thank you.
Thank you, Zambia. I would now like to recognize the delegation of Panama to be followed by the Dominican Republic. Panama, you have the floor.
Thank you, Chairman. Panama is grateful to the Director General for the document which has been submitted and would like to echo the feelings of those countries who have co-sponsored the resolution on the highest possible attainable level of health for persons with disabilities. The Government of Panama, through its National Council on Persons with Disabilities, which is chaired by the President of the Republic and works together with the Ministry of Health, has been taking specific action for some time to further the participation of various associations that work with, for, and through persons with disability in our country. We've been doing this in order to ensure that persons with disability can participate actively together with representatives of the state in decision-making about their health and their rights. We have put data on persons with disabilities into a computer system which makes it easier for them to get access to healthcare and information. We fight against discrimination and the lack of respect for the rights of persons with disabilities. During public health emergencies, of course, the already high level of vulnerability of persons with disability can increase, and that's why we've been working very hard in the course of the COVID-19 pandemic to develop a strategy whereby healthcare can be provided virtually or remotely to persons with disability. This minimizes their need to have close contact with people and reduces their exposure to the COVID-19 virus. We are also working on greater inclusivity in access to good quality healthcare at all times, so that persons with disability can indeed enjoy the highest possible level of health and healthcare. Thank you.
Thank you, Panama. Would now like to recognize the delegation of the Dominican Republic, to be followed by the Philippines. Dominican Republic, you have the floor.
Thank you very much, Chairman. We are very grateful to the Secretariat for having submitted the various reports under this agenda item. Global strategies and plans of action scheduled to expire within 1 year. We're particularly impressed by the report on HIV, on the rights to healthcare of persons with disabilities, and the one on sexually transmitted infections. We're very grateful to Israel for its drafting of the specific resolution on persons with disability, and we would very much like to be included as a co-sponsor of that resolution. We'd also like to thank Namibia for having submitted the resolution on HIV, viral hepatitis, and sexually transmitted infections. And there again, the Dominican Republic would like to be a co-sponsor of the resolution. Thank you very much.
Thank you. I would now like to give the floor to the delegation of the Philippines, to be followed by Guatemala. Philippines, you have the floor.
Thank you, Chair. The Philippines commits continuous support to global initiatives to ensure better health for all people with disability. Adopting the WHO Global Disability Action Plan 2014 to 2021, the country's National Action Framework for the Health and Wellness Program of Persons with Disabilities centers on 3 areas. Number 1, removal of barriers to access to health services. 2, expansion of rehabilitation, assistive technology, and community-based rehabilitation. And 3, strengthening collection of relevant and internationally comparable data on disability and support research on disability and related services. We would like to emphasize the gravity of having a global plan of action, and we look forward to actively participating in WHO efforts in developing action plans for 2022 and beyond. We thank the Secretariat for the technical assistance on interagency collaboration in conducting a national disability prevalence survey that is anchored on the SDGs and implemented in consonance with the UN Convention on the Rights of Persons with Disabilities. Meanwhile, the Philippines, faced with the rapidly growing number of HIV cases, is determined to put great effort in the development process of the strategies on HIV, viral hepatitis, and STIs. A key development step is to ensure sufficient platforms for the engagement of people living with the disease, and that high-risk populations are effectively integrated in member states' high-impact prevention, testing, and treatment strategies to achieve the 1990 targets. It is also imperative to have convergence on adaptive plans during the pandemic so that there is sustained testing services and client-centered approach for the delivery of ARVs and other related services. Thank you.
Thank you. I would now like to give the floor to the delegation of Guatemala. You have the floor.
Thank you, Chairman. The Guatemalan delegation would like to acknowledge the importance of the resolution contained in document EB 148-8. We would also reiterate our commitment to achieving the highest possible level of health for persons with disability, which of course is the goal of the resolution. However, the Guatemalan delegation must repeat and do so for the record that it maintains the reservations which, in accordance with national legislation, it put down on the Programme of Action of the International Conference on Population and Development and the Beijing Action Platform. Thank you.
Thank you, Mr. Chair. With your permission, we will now continue with the non-state actors in official relations with WHO. And we will start with those who indicated their interest in speaking under agenda item 19.3 on WHO Global Disability Action Plan 2014-2021. I would like to give the floor to the International Association for Hospice and Palliative Care Incorporated. You have the floor.
Thank you, Chair. The IHPC thanks Israel and member states for including palliative care, an essential health service that relieves preventable suffering, in the draft resolution. We will collaborate with the Secretariat by showing how our global partners care for patients with disabilities, particularly older persons. According to the UN Special Envoy on Disability, the right to palliative care is not subject to progressive realization. It is a fundamental pillar of the right to life and integrity of the people who need it. Experts classify failure to provide palliative care as a form of abandonment and neglect and as cruel, inhuman, or degrading treatment. The IHPC urges member states to consider the WHO recommendations on palliative care for older persons and those with disabilities in the guidelines on clinical management of COVID-19. I thank you.
Thank you. I would like to invite the Handicap International Federation.
Thank you. I hope you can hear me well.
Yes, please go on.
Handicap International, IDDC, and IDA welcome the negotiation of a draft resolution on the highest attainable standard of health for persons with disabilities. We thank the core group and in particular the permanent mission of Israel for their leadership and the inclusive consultations with civil society on the draft. We regard the following elements of the resolution as fundamental: the commitment to moving away from a medical approach to disability and adopting language aligning with the CRPD, reaffirming the rights to health of persons with disabilities and the principle nothing about us without us as a precondition for ensuring disability inclusion, insisting on the involvement of persons with disabilities as essential players in identifying and addressing all barriers to health faced by persons with disabilities. The draft resolution comes at a crucial time, comes at the expiration of the WHO Global Disability Action Plan, comes right after the UN adopted their disability inclusion strategy, and when COVID-19 has been exacerbating existing inequalities. The current situation highlights the urgent need to the right to health without discrimination on the basis of disabilities respected, protected, and fulfilled. To conclude, we confirm our commitment to continue supporting the WHO and the member states in the preparation of the World Report on the highest attainable standards of health for persons with disabilities, the implementation of a UN disability inclusion strategy, and the creation of an inclusive global research agenda. I thank you.
Thank you. We would like to recall the non-state actors of the time limit of 1 minute for your statements, please. Next, I would like to call on the Worldwide Hospice Palliative Care Alliance. You have the floor.
My name is Ashla. I give this intervention on behalf of the Worldwide Hospice Palliative Care Alliance. I fell from a moving train 10 years back and injured my spinal cord. I'm a wheelchair user now. In LMICs like India, any major disability causes serious health-related suffering because of lack of rehabilitation, inaccessible homes and public places, and denial of education and opportunities. In Kerala, I work with a palliative care organization to treat their suffering and to help them live life to its full potential. We also know from projects in Bangladesh that over 90% of people who access palliative care live with disabilities. We request that in future, WHO disability plans and resolutions relating to disability ensure adequate consideration of access to palliative care for people with disabilities. I thank you.
Thank you, Madam. We will now continue with the non-state actors who will speak on the global health sector strategies on respectively HIV, viral hepatitis, and sexually transmitted infections for the period 2016-2021. I would like to give the floor to the World Hepatitis Alliance.
Thank you. The World Hepatitis Alliance welcomes the development of a new global health sector strategy for viral hepatitis. This new strategy will be a vital tool in reaching hepatitis elimination by 2030. Realistic and achievable testing and treatment targets can help find the 290 million people living with viral hepatitis unaware and link them to the care they need. Prevention targets can stop more lives being cut short. The populations most impacted by viral hepatitis are often those most underserved by health systems. Civil society and the affected community are a critical catalyst to ensure that no one is left behind and must be central to the new strategy. They must be an integral part of the planning, implementation, monitoring, and governance of hepatitis elimination programs and services everywhere. The World Hepatitis Alliance and our members in 100 countries stand ready to support the World Health Organization in the development of the new strategy and commit to tirelessly working for its achievement. Thank you.
Thank you. I would now like to give the floor to the Drugs for Neglected Diseases Initiative. Sir, you have the floor.
The NDI welcomes progress in HIV, viral hepatitis, and sexually transmitted infections. However, significant challenges remain to reach the SDG 2030 elimination goals. For hepatitis C, not enough patients are diagnosed and treated, particularly in higher burden countries, often still because of high prices. Actions to remove barriers to scaling up diagnosis and treatment are urgently needed. For HIV, much more needs to be done to scale up access to optimize pediatric antiretroviral formulations, generate the evidence for HIV-exposed infant prophylaxis, and explore new delivery systems for adolescents. For STIs, greater surveillance, development of new tests and treatments, and robust strategies for appropriate use and stewardship will be needed to address alarming rates of drug resistance, for example, for gonorrhea. Progress can only be achieved with political will, development of appropriate health tools, and sustainable financing. I thank you, Chair.
Thank you. And now I would like to give the floor to the Task Force for Global Health Incorporated. Sir, you have the floor.
The Task Force for Global Health supports the WHO renewal of an integrated global strategy, including goals for hepatitis elimination by 2030. WHO leadership is essential, guiding the implementation of vaccination, testing, and curative treatment that makes possible hepatitis elimination and ultimately eradication. In response, member states develop plans and programs. Indeed, with the dramatic declines in the cost of HCV curative medications, countries are steadily implementing simplified models of testing and care within existing health systems and beyond. The new strategy will allow WHO and partners to address and overcome the remaining challenges to hepatitis elimination, including inequities in health for marginalized populations, while spurring the development of new technologies and innovative strategies, including those coming from the COVID-19 response. We look forward to assisting WHO in the development of this global strategy, and together with a coalition of partners assisting WHO and member countries implementing the strategy and achieving goals for hepatitis elimination. Thank you.
Thank you. Mr. Chair, there are no further requests for the floor.
Thank you. If there are no more requests for the floor, I shall request the Secretariat to respond to the questions raised. Secretariat, you have the floor, please.
Thank you very much, Your Excellency. And I would like to call on right away Dr. Mingui, who is the Assistant Director General for Universal Health Coverage, Communicable and Non-Communicable Diseases, to respond to the issues raised. Over to you, Mingui.
Thank you, delegates, for your interventions. In particular, all of your enthusiastic and positive interventions concerning item 19.3. All of your contributions are very constructive. Since we have limited time, I will only focus on a few of the issues raised. First, concerning disability, we appreciate the leadership of Israel and co-sponsoring member states, and we are confident that we will be able to strengthen our work in all areas requested in the draft resolution, including the development of a global research agenda on disability and a global report on the highest attainable standard of health for persons with disability, which will be presented to the WHO in 2023 for your consideration. In addition, the WHO will continue to collect comprehensive and comparable data on disability, as noted by Kenya and other member states. The COVID-19 pandemic has made it challenging for the Secretariat and member states to collect data disaggregated by disability. We will strengthen our support to member states to improve data collection and to share different regions' experience and knowledge as requested in the resolution. The Secretariat believes that there's no need to extend the WHO Global Disability Action Plan 2014 to 2021, nor to develop an action plan on rehabilitation and assistive technologies as requested by Bangladesh. The WHO Rehabilitation 2030 initiative and the WHA Resolution WHA 78.8 on improving access to assistive technology is guiding concrete work by the Secretariat at both national and global levels. As noted in the draft resolution, the Secretariat is actively implementing the UN Disability Inclusion Strategy in WHO. We have already taken actions in 2020, which will be highlighted in the DG's report to the WHO, including launching of the WHO policy on disability by the DG on the 3rd of December, establishment of a steering committee, working group, and a secretariat within the WHO. In addition, we are also working to develop a WHO action plan in line with the general program of work.
By these steps, WHO will systematically integrate disability in its programmatic areas of work and core functions and become more inclusive workplace where people with disability play a vital role in our vision to promote health. The public health approach to disability intrinsically embraces human rights as put forward by Israel, United Kingdom, and many other member states. We must make sure that the full engagement of the people with disabilities. We also take note of the call from the United States and the United Kingdom to ensure that sexual and reproductive health of people with disabilities to be addressed. As during the COVID-19 pandemic, we need to prioritize the work on disability and make it into public health. This has become a more apparent issue. We now have We now are in the preparation of a document on disability consideration during COVID-19 outbreak. Regarding the global health sector strategies on HIV, viral hepatitis, and sexually transmitted infections, we have heard your comments and overwhelming support in the draft resolution to extend these three interlinked strategies to cover the period 2022 and 2030, tabled by Namibia and co-sponsored by Botswana, Australia, USA, and other member states. The three interlinked global strategies have driven progress in many countries. For example, we heard from Botswana on hepatitis, China on HIV and hepatitis, and Indonesia on triple elimination of all these three diseases. Unfortunately, as stated by many member states, if we do not intensify our efforts, we will not be able to achieve our 2030 elimination targets. COVID-19 pandemic has shown to us that in a very short time frame, there can be dramatic change, as proposed by Sudan. We must build a stronger health system that can deliver flexible, people-centered, and quality services relevant to the three disease areas, especially during health emergencies. As requested by Germany, Thailand, and other countries, will seek opportunities to further link with the SDG 3 Global Action Plan, integrate and promote new science and digital approaches, and strengthen surveillance for HIV drug resistance in the development of new strategies, and give due consideration to these issues. We also thank the issues raised by Adalia, Namibia, and Russia Federation to make sure we cover the vulnerable people. The strategies should be informed by the deliberations and outcomes of the proposed UN General Assembly high-level meeting on HIV in June this year, and also, as requested by many member states, we are aligning the development of these three WHO strategies and global targets with those of key partners, including strategies currently under development by UNAIDS and Global Fund to fight AIDS, tuberculosis, and malaria. As put forward by Germany and other countries, we will conduct intensive consultations with member states, including NGOs and other stakeholders, to make sure they are participating in the preparation of this strategy. Meanwhile, we will provide support to member states, especially those with countries, those low and middle income countries with high disease burden, with population at high risk. And we will also support countries to validate the elimination of hepatitis epidemics. At last, thank you for support and guidance.
Thank you very much, ADG Ren Mingui, for his extensive replies to all the issues that member states have raised. And let me thank very much to the member states for the constructive discussion. In the closing remarks, let me reiterate a few issues. First of all, to join ADG, to thank Israel for leading the negotiations on the resolution on disability. It will shape the Secretariat's agenda on disability in line with GPW 13. The Secretariat will make sure that disability is well portrayed through evidence as a public health issue in the work we do. The public health approach to disability intrinsically embraces human rights. Disability is an agenda that is very close to the Director General's heart. He personally requested to develop a disability policy for WHO, which, as you heard, we launched on the 3rd of December, and the action plan is currently being developed. And you will be very pleased to hear that we have even integrated disability in our impact framework, and it is now part of the reporting scorecard. With regard to HIV, viral hepatitis, and STIs, We have been listening carefully to this agenda item, and we have heard your comments and overwhelming support of the resolution to continue and update the 3 interlinked global health sector strategies on HIV, hepatitis, and STIs to cover the period 2022-30. We have 10 years to accomplish the SDGs agenda. We achieved our first SDG goal in 2020, when the under 5 years seroprevalence of hepatitis B reached less than 1%. Yet, we have several more SDG goals to reach, and these strategies will help us to attain these goals of elimination and control of 3 important and deadly communicable diseases. At the same time, we would also like to ask member states to redouble their efforts and reverse the trend of slowed and plateauing results. Lastly, I would like to thank the countries that proposed this resolution, Namibia and Botswana, and the supporters, including Australia, US, EU, among many other member states. Thank you very much. And with this, Excellency, Chair, back to you.
Thank you. As I see no more comments, may I take it that the board is ready to note the reports contained in documents EB 148/36 and EB 148/37? I see no objections. The reports are noted. Let us now consider the conference papers. Is the board ready to adopt the draft resolution on the highest attainable standard of health for persons with disabilities contained in document EB 148/conference/8? I see no objection. The resolution is therefore adopted. Is the board ready to adopt the draft decision on the global health sector strategies on respectively HIV, viral hepatitis, and sexually transmitted infections contained in document EB 148/conference/1? I see no objection. The decision is therefore adopted. Thank you. This concludes our consideration of sub-item 19.3. We shall now continue our consideration of item 13, integrated people-centered eye care including preventable vision impairment and blindness. The floor is now open to continue our discussion on this item. I would like to request that the Secretariat moderate the discussion on the virtual platform. Secretariat, you have the floor, please.
Thank you, Mr. Chair. For the moment, we don't have any request from member states for the floor. Maybe we just wait for a few more seconds. Mr. Chair, as there are no requests from the floor from the member states, with your permission, I would like to continue with non-state actors in official relations with WHO, and I would like to call upon the International Agency for the Prevention of Blindness. Thank you. I would now like to move on to the Royal Commonwealth Society for the Blind. Oh, I apologize. It seems that we do have the International Agency for the Prevention of Blindness online. Please, Madam, you have the floor. Mr. Chair, 2 member states have requested the floor. So before going back to the NSA, I would like to give the floor to Thailand, to be followed by Peru. Thailand, you have the floor.
Thank you, Chair. The Integrated People Center iCare will align with our universal health coverage. Thailand thanks the Secretariat for the development of global targets on these important agendas. While Thailand supports the global targets for 2030 effective coverages of cataract surgery and eyeglasses for refractive errors, we would like to register 2 major concerns. First, while we promote the service coverage, we should avoid unnecessary cataract surgery. To meet this, an appropriate preoperative visual acuity should routinely be used as an efficient clinical indication in setting the eligibility criteria for cataract removal. Second, evidence shows that prevalence of blindness and visual impairment are gradually decreasing. The proposed targets, we believe, will further drive up the effort to address refractive error and cataract. Chair, however, we are shockingly worried about the sharp rise of the diabetic eye diseases. To be accurate, the diabetic eye diseases doubled the figure over the last 2 decades, from 0.2 to 0.4 million. Thailand has developed implementation diabetic retinal screening trial by artificial intelligence technology and utilization this new technology in rural areas for the achievement of preventable visual impairment. Thailand expects that AI technology such as data mining, machine learning, and using the WHO guidelines on integrated care for older people program would improve coverage and make early detection for eye diseases. Thank you.
Thank you, Thailand. I now call upon the delegation of Peru to take the floor.
Muchas gracias, señora moderadora.
Moderator.
Agradecemos a la Secretaría
We are grateful to the Secretariat
por la elaboración de las metas globales
for having
2030
prepared
sobre atención oftalmica
global goals
integrada
for 2030,
y centrada en la
covering
persona
integrated
como
people-centered eye
seguimiento a
care,
la resolución 73.4 de la
vision impairment and
pasada Asamblea
blindness
Mundial
as
de
a
la
follow-up
Salud, que el Perú
to
tuvo el placer de
Resolution
copatrocinar.
WHA 73.4, which was adopted at the last World Health Assembly and of which Peru was a co-sponsor.
Creemos que es necesario que los indicadores
We
de las
believe
seguridad
that it is essential for the indicators
sean prácticos,
for
implementables y
the
económicamente
goals be
viables,
practical,
presentando
easy to
que
implement,
para
and
la
economically
debida
viable.
aplicación también es fundamental contar con el
In
apoyo
order to ensure
técnico
that they're applied properly, we
financiero
also
de la
need
OMS,
technical and
la
financial support
Organización
from the World Health
Panamericana de la Salud.
Organization and from, in our case, the Pan American Health Organization.
En el Perú, los problemas visuales son la segunda causa de
Sight
discapacidad.
problems are the second cause of disability, the second most frequent cause of disability.
E involucran cifras, según las cifras del año 2020, a
According to the
más
figures we have
de
available for last
300.000
year,
personas
over
con discapacidad visual
300,000
severa,
people suffer from
160.000
severe
personas
visual
con ceguera por
impairment,
diversas
and
causas. La
160,000 are
principal
blind.
causa de
The
ceguera
blindness
e impedimento
caused
visual
by
severo
different things. The main cause of
es la
blindness
catarata no
and
tratada,
severe
mientras que la principal causa de impedimento visual moderado
disability
son
is
los errores
untreated
refractivos.
cataract, and the main causes of moderate visual impairment, long and short-sightedness.
La discapacidad por ceguera muchas veces que es prevenible tiene un gran impacto en el
Blindness
bienestar
is
y la
often
calidad de vida de
preventable,
las
but when
personas que
people
la
do go
padecen
blind, it has a
por su
terrible
alto
impact on their
componente de
well-being and their
invalidez.
quality of life, because
Teniendo en cuenta lo
it is so
anterior, en el
disabling.
Perú se ha venido
Bearing this in mind,
fortaleciendo
in
en los
Peru over
últimos
recent
años
years we have
la
been
gestión de salud
strengthening
ocular
the way in
con el
which we
objetivo de lograr
manage
la
eye care,
integración de
so
la
as to
atención
ensure
oftalmica
that
en los
it
servicios
is
nacionales de salud,
included in our
en
national
particular
health service,
en el nivel de
and
atención primaria,
particularly at
con la finalidad de
care level.
mejorar el
We
acceso
hope
a
this will
servicios de
improve
salud
access to eye care,
popular con calidad y oportunidad en nuestra
good
población.
eye care for the population as and when they need it.
Con estos comentarios, el Perú
With these
toma nota del
comments, we would
informe
like to take
contenido en el
note of the
documento
report
EB
contained in
148/15.
document EB
Muchísimas gracias.
148/15. Thank you.
Thank you, Peru. I'm now going back to the list of the non-state actors, and I would like to call upon the Royal Commonwealth Society for Blind Sightsavers.
Sightsavers welcomes the report of the Director General on Integrated People-Centred Eye Care. Having targets will support our states to take concrete steps to improve eye health coverage. We feel the targets for effective coverage of refractive error and effective coverage of cataract surgery are ambitious but achievable. We would urge Member States to ensure that these targets are achieved in all sectors of the population. However, we ask Member States to take note of the wide range of eye conditions that also need addressing while working towards achieving these targets. We would welcome more discussion on the inclusion of all of society, women, children, people with disabilities, and refer Member States to the World Report on Vision and its call for all population through integrated people-centred eye care. Resolution 73.4 called on the Director General to provide technical support to Member States to achieve integrated people-centred eye care and to integrate eye care into universal health coverage. We, along with others in the sector, stand ready to support Member States to implement recommendations as part of broader engagement on universal health coverage. We recognise that the coming year will continue to have challenges that arise from the COVID-19 pandemic, and we will support Member States to work towards the integration of eye care in universal health coverage. We encourage the Executive Board to endorse the targets so that they can be formally adopted by all Member States at the 74th World Health Assembly. Thank you.
Thank you. I would now like to call upon Medicus Mundi International Network Health for All. You have the floor.
Am I audible?
Yes, please go ahead.
This statement by MMI is supported by PHM. We are concerned that the suggested indicator should not pave the way for fragmenting eye care services or lead to condition-specific vertical programs, eventually resulting in the privatization of eye care services. Publicly delivered comprehensive eye care services need to include early screening and diagnosis of related issues. Data on community-level vision rehabilitation services and access to assistive devices for untreated vision impairment contribute to the continuum of care. Private sector is identified as a stakeholder, yet the enabling role of eye care in public health systems in LMICs is ignored. Integrated primary eye care with strong accountability mechanisms is required, as well as working closely with communities on social and environmental determinants of ocular health. Training of the health workforce, diagnostics, and screening at the primary level are required to ensure access in remote locations, with community health workers and communities playing a prominent role. Thank you, Chair.
Thank you, Madam. I would now like to call upon the International Agency for the Prevention of Blindness. Ma'am, you have the floor. I would now like to give the floor to the delegation of Sudan. Sudan, you have the floor.
We commend effort exerted by WHO to set feasible global targets for 2030 on integrated people-centered eye care, focusing on effective coverage of refractive error and effective coverage of cataract surgery. The primary causes of blindness in Sudan are cataract, glaucoma, trachoma, and onchocerciasis. These causes were responsible for 60%, 20%, 15%, and 5% of blindness, respectively. Sudan launched the Vision 2020 program in 2003. Since then, tremendous effort was exerted in targeting the leading causes of avoidable blindness in the country. Effort was also exerted.
Could the speaker slow down a bit for the benefit of the interpreters, please?
Dan, I do apologize for interrupting you. Can you please start again but speak slower? The translator have a rough time following up with you. Thank you.
Sudan welcomes a report on integrated people-centered eye care, including 30 on integrated people-centered eye care, focusing on effective coverage of refractive error and effective coverage of cataract surgery. The primary causes of blindness in Sudan are cataract, glaucoma, trachoma, and onchocerciasis.
Sudan launched the Vision 2020 program in 2003. Since then, tremendous effort was exerted in targeting the leading cause of avoidable blindness in the country. Effort was also exerted to reduce the prevalence of blindness, as in 2003 was 1.5%, in 2010 was 0.7%, and it's expected to be 0.3% in 2020. As a result of these efforts, a very significant progress was achieved. In particular, for the leading cause of blindness, cataract, the total number of surgeries increased from 18,000 to more than 80,000 operations per year. And consequently, the CSR increased to 2,500 surgeries, which has exceeded the WHO threshold. Which is a second cause as well, there is good progress on the needed in the coming years to sustain and accelerate this progress. We urge the WHO to set visual impairment high on the global health agenda, as it is vitally contributing to achieving several goals related to public health, such as equitable learning, education opportunities, and sustainable economic growth with prevention of poverty. The current situation in Sudan shows more effort and more investment is needed to push forward the adoption of the national strategy with the aim to achieve avoidable blindness and visual impairment. Sudan highly appreciates the spare no effort approach by WHO towards eye care and strongly supports the recommended feasible global targets for effective coverage of refractive error and for effective coverage of cataract surgery, as we are steadily working towards these targets by improving the quality and availability of eye care health services, such as regular screening for REs in basic schools and improving access to cataract surgery across all the states of Sudan. Thank you.
Thank you, Sudan. Mr. Chair, there are no further requests for the floor.
Thank you. If there are no more requests for the floor, I shall ask the Secretariat to respond to the questions raised. Secretariat, you may have the floor.
Thank you very much, Mr. President. Let me hand over to ADG Remingui right away for his replies. ADG Remingui, UHC, communicable, non-communicable diseases. You have the floor, please.
Thank you, Susanna. We thank the member states and non-state actors for your comments, and also would like to take the opportunity to express our sincere thanks to you and for your very constructive input in the consultative process to develop recommendations on feasible global target for the 2030 eye care conducted by Secretariat during June and November last year, in accordance with Resolution WHA 73.4. These recommendations on effective refractive area coverage and the effective cataract surgery coverage has been supported by member states in general. That's what I understand from the deliberation. Many of the comments raised during the discussion are reflected as well in the draft resolution, in the resolution WHA 73.4 on integrated people-centered eye care, including preventable vision impairment and blindness. You can rest assured the Secretariat is currently developing a suite of technical tools and guidance, including the package of evidence-based eye care interventions and the global research agenda for eye health to support member states to build capacity and strengthen eye cares within their health systems. The Thai and other member states highlight the importance, which is absolutely right, of diabetes related to the eye disease. Please also be sure that WHO is taking a cross-programmatic approach to diabetes and its related vision impairment, which will be included as a part of global diabetes compound. I will now briefly focus on responding some of the specific comments raised, especially in the context of indicators and their respective targets. First of all, it is important to emphasize the effective refractive error coverage and effective cataract surgery coverage serve as trace indicators to monitor eye care and universal health coverage at the global level. To accomplish these targets, the Secretariat is developing a much more comprehensive menus of indicators for monitoring the progress of eye care sectors at national and subnational levels. This comprehensive menu also includes indicators for other eye conditions such as glaucoma. The secretariats acknowledge that being able to collect a large volume of data periodically will be critical to ensure the robust monitoring of progress towards achieving the indicator's target. To this end, working is underway to develop a valid, reliable, and feasible data collection methodology that can be implemented as standalone measures or to be integrated into existing surveys. Recognizing the importance of equity data will need to be collected, analyzed, and reported in a straightforward manner when monitoring the two indicators. The Secretariat commits to support the member states with technical advice and the tools with data, especially data disaggregated by age, gender, socio-economic status, geography, and any other relevant country-specific social democratic stratifiers. Work is also underway to incorporate vision modules within existing WHO health surveys, including the steps to promote more widespread data collection on the two indicators. And the Secretariat was engaged with stakeholders, including the private sector, in efforts to raise funding to support intermediaries conductors of country-level data collections on the selected indicators. The Secretariat, together with our partners, is working to analyze existing data to establish robust baseline estimate for the two indicators that will be presented to the member states in the coming days. Further to this, the tools linked to the package of eye care interventions and the WHO One Health tool is being created to support countries in planning and costing towards increasing effective cataract surgery coverage and effective retroactive error coverage. With that, I thank you again for your support and guidance.
Thank you very much, ADG Bingui. And with this, President, back to you.
Thank you. As I see no more comments, may I take it that the board is ready to note the report contained in document EB 148/15? I see no objection. The report is noted. This concludes the board's consideration of item 13. We shall now consider sub-item 14.4, the public health implications of implementation of the Nagoya Protocol. The report by the Director General is contained in document EB 148/21. The Executive Board is invited to note this report and consider recommending that the Health Assembly request the Secretariat to continue its work in this area with a specific focus on options to provide additional transparency, equity, clarity, and consistency in pathogen sharing practices globally and to increase capacity worldwide for both the sequencing of pathogen genomes and the analysis of those genomes. The floor is now open for discussion. I would like to request that the Secretariat moderate the discussion on the virtual platform. Secretariat, you may have the floor.
Thank you, Mr. Chair. I would now like to recognize the delegation of Austria to be followed by China. Austria, you have the floor.
Three candidate countries, the Republic of North Macedonia, Montenegro, and Albania, the country of the stabilization and association process, and potential candidates, Bosnia and Herzegovina, as well as Ukraine and the Republic of Moldova, aligned themselves with this statement. The EU and its member states would like to start by acknowledging the critical role
the GISRIS network and the non-WHO coordinated platforms, such as the European Virus Archive, GIS-Aid and GenBank have had in the monitoring of the COVID-19 virus by enabling efficient sharing of materials and genetic sequences. These platforms have proven they can render services for many diseases other than influenza and can as such be regarded as global public good. We thank the Secretariat for the comprehensive report on access to and benefit sharing of pathogens within the context of the Nagoya Protocol and beyond. We agree with the conclusion of the report that significant public health benefits can be drawn from timely and efficient pathogen and benefit sharing. Despite the low participation rate, the survey carried out demonstrates clearly that there is a multitude of different contexts and approaches in pathogen sharing. A major part of these arrangements are often without provisions for benefit sharing based on local, personal, bilateral, and other informal arrangements. Furthermore, there seems to be only limited clarity in differentiating the sharing of biological pathogen samples and genetic sequences. The picture is further blurred by the limited implementation of the non-compulsory pathogen-related provisions of the Nagoya Protocol in the national access and benefit sharing legislation of countries that are parties to the protocol. Obviously, as a response to this complex, or if you like, confusing situation, WHO has recently announced the establishment of a WHO repository for biological materials. While waiting to learn more about this new initiative on pathogens and benefit sharing, we look forward to its development in a transparent process in consultation with member states. Mr. President, the EU and its member states would like to draw three conclusions. First, it seems that pathogens, in particular in health emergencies, should not be treated the same way as other genetic resources. Second, one cannot avoid getting the impression that the world is currently extremely vulnerable in the face of the legal uncertainty on timely access to pathogens in health emergencies, since this uncertainty could cause delay in access to diagnostic, therapeutics, and vaccine. Third, as there is an apparent need for improvement, we're looking forward to recommendations on timely pathogen and benefit sharing from the current review and assessment bodies, including the IHR Review Committee. Chair, it is indispensable that the work of the Secretariat on approaches to pathogen and benefit sharing, including sharing of influenza viruses within the GISRIS network and their concrete impact on timely public health actions, needs to continue, and that WHA should continue to be informed of the results to take whatever concrete steps are collectively decided to be necessary. Thank you very much. Thank you, Austria. I would now like to recognize the delegation of China to be followed by Indonesia. China, you have the floor.
Thank you, Chair. The Chinese delegation thanks the Secretariat for its support and appreciates WHO's work in biodiversity and health, as well as the access and benefit sharing. China supports the implementation. It is urgent need to establish a fair and equitable benefit sharing mechanism. WHO should work closely with all stakeholders to ensure emergencies member states can rapidly share pathogen, genome sequencing, and metadata. Since 2016, when China joined officially the Nagoya Protocol, it has been working hard to fulfill its responsibility and obligation in promoting access to genetic resources and fair and equitable sharing of benefits. Concerning the sharing of influenza virus, China respects the principle of equitable sharing and the principle of national sovereignty on its biological resources, and shared between 2003 and 2020, 3,871 seasonal influenza virus strains with other countries to be used in vaccine development, evaluation, and medicine analysis. Since 2011, China has received from other countries 906 seasonal influenza virus strains. Between 2013 and 2020, China shared with other countries 46 human avian influenza strains, and since 2011, it has received 7. Concerning the sharing of SARS-CoV-2 virus, since the outbreak, China immediately mobilized high-level biological security labs with leading expertise to conduct a parallel testing for cases and samples, and within a record-breaking time period, they identified SARS-CoV-2 as pathogen and immediately shared its genome sequencing through GSAID. The genome sequencing shared immediately by China provided the world with important basic information to be used in clinical diagnostic, medicine selection, vaccine research, origin tracing, virus evolution, and many other studies. This is highly appreciated by WHO and the international society. Chinese government is committed to public health and is willing to work with other member states to fulfill the obligations while respecting country sovereignty, protocol implementation process, and China is also accelerating the development and implementation of related laws and regulations to ensure the timely publication and the sharing of information and regular reviews. We support the fair and equitable sharing mechanism and is willing to better fulfill its obligation and contribute further to the global public health. Thank you.
Thank you, China. We now like to call upon the delegation of Indonesia to be followed by the United States of America. Indonesia, you have the floor.
Before closing, sir, जैसे ये last when they hand back to you, तो एक बार टीम को hand कर दीजिएगा for an announcement.
We note also the effort to have a broad reach in collecting data on current human pathogen sharing practices and arrangements, and implementation of access and benefit sharing measures, as well as opinions on the public health implication of both. We note the survey was completed by 118 respondents, and only 21 respondents, or 18%, were from member states, which the responding countries are not specified. The proportion of non-state respondents are also not specified. Therefore, we could not confirm the validity of the result of this survey. More so, the survey should be more comprehensive and not too focused on getting information related to the access, but also on the benefit sharing measure. Chair, WHO should be careful in selecting specific notes from the survey and stating them in the report. Indeed, 65% of WHO members are parties to the Nagoya Protocol, and all WHO members are parties to the Convention of Biological Diversity, or CBD, which, among others, regulates fair and equitable benefit sharing of pathogens by virtue of the CBD. Moreover, 2/3 of WHO members have recognized the premise and rights of the Nagoya Protocol. The rights granted to the member states by the CBD and the Nagoya Protocol should be respected and upheld, and their national access and benefit sharing legislation should be recognized and supported. Chair, a timely pathogen sharing is important to address public health needs, especially during the pandemic. We appreciate the initiative taken by WHO and others. However, we believe that should WHO plan to develop a new sharing mechanism, the decision to develop such mechanisms should be done through intergovernmental process with active and inclusive participation of member states. The mechanisms must be well structured, systematic, and begins by addressing these questions, such as what pathogen samples are shared, who will share them, with whom, as well as when, where, and how the samples are shared. To conclude, Chair, Indonesia is open for further consultation on this matter. I thank you.
Thank you, Indonesia. I would now like to give the floor to the United States of America to be followed by India. US, you have the floor.
Thank you, Madam Moderator. The United States thanks WHO for the report on the public health implications of implementation of the Nagoya Protocol that details the results from the all-stakeholder survey. Combating pandemics and other infectious disease threats depends on effective biosurveillance, transparent outbreak reporting, and the rapid sharing of pathogens, clinical materials, and information, including genetic sequence data. This sharing is critical for surveillance, rapid development and deployment of diagnostics, therapeutics, and vaccines, as well as to monitor for the emergence and spread of novel variants with potentially increased transmissibility, virulence, or that could render existing medical countermeasures less effective or ineffective. We support the interim progress report of the IHR Review Committee, which emphasizes the Review Committee's consideration on the need to optimize procedures for rapid and transparent sharing of pathogens, specimens, and sequence information. The U.S. government has made available to international researchers key SARS-CoV-2 virus samples isolated from within the U.S. through a biorepository, BEI resources. Through BEI, the National Institute of Allergy and Infectious Diseases has shared these more than 4,500 times under an MTA that promotes the non-restrictive sharing of SARS-CoV-2 material with diverse stakeholders in at least 49 countries, including government scientists, academics, and private sector companies, for any legitimate purpose required to study, rapidly detect, prepare for, and respond to COVID-19. We urge WHO to continue to raise awareness of the critical importance of rapid sharing and to encourage member states to rapidly share pathogen samples, genetic sequence data, and other related information, especially during health emergencies. At the closing session of WHA 73 on November 13th, Dr. Tedros announced a proposal for the WHO BioHub, and we received a few more details over the past few days. We are interested in learning more about this proposal and how the WHO proposes to balance the many complex issues around pathogen sharing, including the need for rapid sharing during emergencies, the potential terms related to such sharing, and biosecurity. Given that many biobanks already exist, we also wish to understand the gaps that the proposed WHO biorepository seeks to fill. We caution that this is a complex issue to navigate in normal circumstances, let alone when member states and the WHO The United States supports the Secretariat's request to continue its work on these important issues and encourages member states to work during the intersessional period to offer guidance on how to provide additional transparency and clarity on pathogen sharing practices globally, especially during public health emergencies. Thank you.
Thank you, the US. I now invite India to be followed by the United Arab Emirates. India, you have the floor.
Thank you, Mr. Chair and Madam Moderator. India believes that the challenges faced during COVID-19 pandemic have highlighted the need for rapid and timely exchange of genetic data and findings in the context of any future public health emergencies. India has actively contributed to the Nagoya Protocol since it was launched in 2014. Over the last year, member nations witnessed the benefits of the protocol play out in response to the pandemic. It facilitated the rapid sharing of information about COVID-19 virus and helped in establishing a systematic, organized method of data exchange to prevent any potential breaches in the country's jurisdiction related to sharing and use of its biological data and resources. Mr. Chair, the need of the hour is to forge more partnership with the research institutions so as to share sequences almost instantaneously across the world at low cost. India appreciates WHO's proactive efforts in this direction in organizing a survey for all member nations in consultation with various international organizations. This enabled a greater understanding of the landscape of pathogen sharing and access and benefit sharing arrangements. The establishment of WHO COVID-19 reference laboratory network is expected to support capacity building of laboratories for both the sequencing and pathogen genomes and the analysis of those genomes. This will help in building a global repository of well-characterized viral strains and sequences, tracking the evolution of COVID-19 virus, and finally contributing towards vaccine development, particularly in middle and low-income countries. On similar lines, the Director General announced the creation of a new repository, BioHub, for specimens at a secure facility in Switzerland to facilitate the voluntary sharing of viruses and rapid development of medical countermeasures. We request for further details on the regulatory framework of this facility and measures to ensure the fair and equitable sharing of these benefits. Mr. Chair, as we know that the report was published late and given that the issues of Nagoya Protocol fall under the mandate of multiple stakeholders within national governments, we recommend that the matter be allowed for further detailed discussions before the Executive Board takes any further decision today. I thank you, Mr. Chair.
Thank you, India. I would now like to call upon the delegation of the United Arab Emirates to take the floor. Ma'am, you have the floor.
Thank you. Esteemed Chair, members of the EB, ladies and gentlemen, on behalf of the countries in the Eastern Mediterranean region, we would like to thank the Director General.
The interpretation apologizes. The quality of the sound does not help.
Excuse me, the Emirates. Unfortunately, we have technical problems in hearing your statement. So, if we still have background noise which prevents translation to hear correctly, maybe we just move on to Bangladesh, and we will try to come back to you right after Bangladesh. Bangladesh, you have the floor.
Trying to get their DG, but we have not been confirmed about the DG's presence. Okay, so WHO.
Bangladesh, just to confirm, are you asking for the floor on this agenda item?
5 minutes. 5 minutes only. Yeah, 5 minutes only.
Bangladesh, we can hear you. Are you taking the floor now? Okay. Thank you, Bangladesh. We understand that you are asking for 5 minutes. Mr. Chair.
Thank you, Secretariat. Before I formally close the meeting, I understand Mr. Tim wants to make some announcements. Mr. Tim, you can have the floor, please.
Thank you very much, Chair. Just like to thank you for the opportunity just to make an announcement in relationship to the proposed program of work for tomorrow. We will reconvene at 10 a.m. tomorrow morning, Central European time. We, through you, Chair, will continue this item 14.4, the public health implications of the Nagoya Protocol. Following that item, that will then leave us 3 more items for tomorrow's work. That is 19.6, provisional agenda of WHA 74 and the date and place of EB 149. 20.1, foundation committees and selection panels. And 22, report on meetings of the expert advisory panels and committees. I'd just like to take this opportunity, Mr. Chair, to alert delegates that item 19.6, provisional agenda of WHA 74 and date and place of EB 149 will take place at 2 o'clock. That's 1400 Central European time tomorrow. So with that, Mr. Chair, I thank you very much and hand the floor back to you.
Thank you, Tim. Excellencies, distinguished delegates, we have come to the end of today's discussions. I thank you all for the rich and very useful discussions. Discussion on agenda item 14.4 is suspended for the moment. We will reconvene tomorrow at 10 a.m. Central European time to resume our discussions. Have a good night and see you once again tomorrow morning. Thank you.